Yeah.
Okay.
So please go live. We want to be
Yeah.
on.
We will go live in 10 seconds.
Okay.
Okay.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतं शङ्करं प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती
Good evening, everyone. Hi, I'm Dr. Rohan Palchetkar, and welcome to the Obstetrics Masterclass today on the 9th of December. This Obstetrics Masterclass has been the brainchild of Dr. Jaideep Tank, with the co-convener being Dr. Parikshit Tank, with the moderators being Dr. Apurva Palam Reddy, Dr. Niharika Malhotra, Dr. Priyankur Roy, and myself, Dr. Rohan Palchetkar. Today's program is going to be slightly different from the regular obstetrics masterclasses. We're going to have two panel discussions, and we're going to be having a live discussion and question answer as well. Without taking too much time, I want to introduce our chief guest, Dr. Shirish Sheth sir, for the forward-looking statement. Dr. Shirish Sheth sir requires actually no introduction. He has been the president of FIGO, the president of the Foxy Society 1990 and 1991. He's also an honorary professor, obstetrician and gynecologist for King Edward Memorial Hospital and St. GS Medical College for over 30 years. Sir has performed performed vaginal surgeries for operative workshops 6 times in London plus 7 other countries. Sir has also received the honorary fellowship and membership of RCOG. Sir, over to you for your forward-looking statement.
Thank you, Dr. Rohan. It's nice to see Dr. Jaideep Chak and Parikshit also in picture, and Dr. Raina, Niharika, and if I'm missing some names, forgive me. It's a great pleasure to be part of this good scientific program. Trophoblastic, something very important. Prenatal, something very important. And that is going to be brought out in a very practical and very important way. It's fascinating. You know, we have seen vesicular mole or trophoblastic when there was no sonography. Jaideep, you and your papa and myself, no sonography, and we make a diagnosis of query vesicular mole. From there, the science has gone so far with sonography and beta HCG and whatnot. But what is very vital for everyone is the follow-up. Follow-up is very important because it can uncommonly but play havoc. And therefore, it becomes a very fascinating. Honestly, truly speaking, you know, it's nicely told by Shakespeare that our doubts are our traitors and oft make us lose the good by fearing to attempt. And keeping that in mind, I think one would surely treat this. And the prenatal reports, plenty. Very important, I must tell you, which we see out of experience. It may be sonography, it may be particular report, but we must slowly develop the most reliable place whose reports are likely to be the closest to the correct. Everybody can make mistake. It's nicely said, there is no man born out of woman who has not made a mistake. But still the closest and most reliable, because based on that report, may it be urine, may it be blood, may it be chorionic or percutaneous something, but those reports will guide us to take a decision. And therefore, I would say that clinical sense, which is very vital, and then it is really superadded by these reports. It is nicely said also by Napoleon, ability without opportunity is of no avail. And tell me in which country you can have more opportunity, more you try, more pregnancies, more deliveries and hysterectomies, except for China, which country can have, and therefore Napoleon's words can really be utilized well. I'm really thankful to all of you. I'm not giving individual names, but all of you for inviting me to be at the helm of it to say these few words. And I wish from the bottom of my heart all the best to you colleagues, as India and our country and our city gives you so much of rich material, clinical material, develop clinical sense, then come to investigation if required, and if the pocket or purse permits, and come to the treatment which is in the best interest of the patient. Thanks a lot.
Thank you very much, Dr. Sirish Sheth. It's always such a pleasure listening to you. I have almost grown up with Dr. Sirish Sheth. I know Dr. Sirish Sheth since I was a child, and my fascination with his ability to convey his thoughts, the way he is so particular in his daily routine, has always fascinated me so much. There is one connection which I must share over here. The first Foxy conference I ever attended was when Dr. Sirish Sheth was installed as the president of Foxy. So that will always be a very, very special memory for me. Thank you very much again, Dr. Sirish Sheth. I know
Thank
you
you.
have a busy schedule. I'm very grateful that you took time off and was a part of it. And I also must say it was a pleasure to see Silo Auntie very briefly, but see Silu Auntie after such a long
She's
time.
sitting next to me and listening. Go on, go on.
Thank you, Sri. So we have two very fascinating panel discussions today. They are both on topics which are controversial, which are topical, and which are of great interest in modern obstetrics. Our first panel is on gestational trophoblastic disease. And when we were looking for a moderator for this, I could really think of no other name than Dr. P.K. Shekharan. I'm sure Rohan will introduce him, but he is really one of the leading workers on gestational trophoblastic disease. And again, memory, one of my first exposures to the inner workings of Foxy was through Dr. P.K. Shekharan when he had stood for an election. I don't know whether Sir will remember, but the way Sir had behaved at that time has really stood in my memory. And at that time, I had said that if Foxy has people like Dr. P.K. Shekharan, then I must also be a part of Foxy. I would like to thank very much all our very, very eminent panelists. There's Dr. Haresh Doshi, someone whom I've greatly admired. Sir, that lecture you gave in the Ahmedabad Yuva Foxy, I will always remember. Such a wonderful lecture you had given. Dr. Maninder Ahuja, someone who was always ahead of her time with all her thinking about e-voting and emails and so on. Our very, very efficient chair of the Onco committee, Dr. Bhagyalakshmi, someone whom again I have known for a while, Dr. Sarita Agarwal, the newly crowned, if I may say, HOD of BHU, Dr. Uma Pandey, and of course the very efficient secretary of Noida, Dr. Anshu Raina. Rohan, I will hand it back to you and I will come back after the first panel gets over to thank the second panelist. So thank you very much again, Dr. Sirish Sheth and Dr. P.K. Shekharan and all the panelists for being here. Rohan?
I don't think I'll be able to do justice after the way you have already introduced, given a quick introduction to moderators and panelists. Let me now just get to introduce
Corner,
for this session. It's Dr. P.K. Shekharan, sir. He was the Vice President Foxy and also the President of the Kerala Federation of OBGY. And he's also been the chair of the World Congress of Gestational Trophoblastic Disease 2009. Our panelists for this session are Dr. Harish Doshi, Vice President FOXY 2019, and he's also the professor and HOD at the GCS Medical College, Ahmedabad. Dr. Maninder Ahuja, the Vice President of FOXY in 2013, and she's the founder president of the Society of Meaningful Life Management. Dr. Bhagyalakshmi Nayak, the chairperson of the Oncology Committee and the associate professor at AHPGIC, Cuttack. Dr. Sarita Agarwal, she's the professor and HOD and the associate dean of the All Institute of Medical Sciences, Raipur. Dr. Uma Pandey, she's the professor, Institute of Medical Sciences, Varanasi, and she's also the Varanasi OBGY Society president. And last but not least, Dr. Anshu Raina, she's the secretary of the Noida OBGY Society, and she was the joint secretary of the North Zone UA FOXY 2019. PK Sekran sir, over to you for the panel.
Thank you, Roshan. Thank you, Shirish sir, for that wonderful introduction. We have enjoyed your company for a long time, and God bless all of us with your blessings that we are starting with your permission. Thank you very much. Okay, we are all aware of the trophoblastic disease is one of the malignancies, one of the most curable of all the malignancies. Can I share my slide? Okay.
Yes, sir.
Okay, so this is one of the most curable condition. If you, as sir was telling, you have to only thing you have to follow the cases after evacuation, and after regular follow-up, you will pick up the cases of malignancy at a very early stage, and you can get a very good cure in this condition, thanks to the development of the chemotherapeutic agents, availability of it, thanks to the very sensitive tumor marker beta HCG, the amount of the volume of which will tell the amount of the, the volume of the disease also. And this has made possible that low risk GTN is almost 100% curable, and even metastatic disease can have almost 95+% of cure with retaining the fertility capacity. That is the other thing. This is the cancer where you can treat and then she can conceive and have children further. So such a cancer. Since the time was allotted was just sufficient to have some case scenario so that it may be practical to think of. I'll first go to Professor Maninder Ahuja. The case is that she's a 50-year-old lady reported with a slight bleeding PV. Actually, she was one of the bystander. I was the bystander for her daughter when she was admitted for delivery, and we thought this lady has got some perimenopausal bleeding. The uterus was about 10 weeks, size 8 to 10 weeks. We did a scan, and that showed to our surprise it is a molar pregnancy. So she is 50-year-old, last childbirth about 10-15 years back, and then 2 months amenorrhea, 2.5 months amenorrhea, and a bulky uterus, and the scan shows. Now, my request to Dr. Maninder will be how should we proceed with this case? It is a diagnosed case of molar pregnancy.
Yeah. Thank you, Dr. Shekharan, for giving me this opportunity to talk on a very subject where you have already highlighted that the patients have to be counseling is the most important thing. But before I start with the case discussion, I have to thank Dr. Jaideep Tong for this innovative steps of OS series, Obstetrics Complete O2S series, master classes, I think which we are taking each subject threadbare so that all the gynecologists, they are clear about the very controversies which are arising out of the subject. Now, Dr. P.K. Shekharan, I am sure you are going to guide all the panelists through a very beautiful panel. And when we talk about this 50 years lady who has come to us and you have diagnosed her molar pregnancy, but still many things are still to be confirmed because you just said the molar pregnancy, because gestational trophoblastic diseases is a wide spectrum of disease which consists of from molar to partial molar to complete molar to choriocarcinoma and placental site tumors and the epithelial cell tumors. So that way the only this complete assessment of the patient is required. We start with the management of the patient. But before that starts the counseling of the patient. At each and every step in this patient, counseling of the patient is very important, that she has to come for the follow-up treatment, at whatever stage we are advising. Though she thought She didn't know perhaps because this age group whether she was pregnant or not, but it started at somewhat of a pregnancy which ended up into a tumor. But it is 100% curable. That is what we have to tell. But then she has to come for the follow-up. This thing should be impressed upon her at every stage of this thing, her follow-up and treatment. So once we start with this patient, we have to go history of miscarriages, whether this followed a normal pregnancy, when was the last pregnancy, because the risk for GTN, gestational trophoblastic neoplasia, is more if the patient had a normal pregnancy more than 4 years back, or even if she had a miscarriage, rather less than after last if she had a molar pregnancy or not. So proper taking history is very, very important. Then we have to go into whether, because we are thinking might be a molar pregnancy, whether she already has had secondary somewhere. So any history of cough, dyspnea, or any neurological signs, then we have to investigate for the chest problems, X-ray, brain CT scan, or MI scan. And of course, when we are doing the TBS, we should be doing the abdominal ultrasound also. Because we have already diagnosed, so I don't think she had any symptoms of hyperemesis, hyperthyroidism, which are so common in these cases. Now, because of the early diagnosis of these conditions, we hardly find those symptoms at all. But what we have to do is, of course, the CBC and blood grouping is very, very important in these cases, and arrangement for blood depending upon how the size of the uterus is there, though it's just 10 weeks in this case, we have been told. But beta HCG levels are something which is very, very important, which should be done at the baseline, and then they have to be repeated again as per the requirement of the patient. And then routine, because she is 50 years lady who has come to us, so we just can't go on thinking with the horses blinkers on that she is just molar pregnancy and we don't have to do other investigation, because this is one opportunity we are getting. So we have to do complete blood sugar, KFT, lipid profile, and look at her cervix also. Then we have to tell her that this is your pregnancy, we'll do your evacuation. We have raised beta HCG levels, maybe then beta HCG levels stratification can also be done, whether it's less than 20,000 or more than 20,000, whether her uterus size is less than 16 weeks. So then at that time, we can do at our own gynecological setups also, but a senior person for evacuation should be there. And then after evacuation, before I talk about the evacuation, we have to talk about anti-D prophylaxis also. And later on, we'll be talking about contraception and everything. So how to do evacuation in these cases? It has to be a rapid evacuation under ultrasound guided, and we can use a bigger cannula, 10 to 12 mm, so that the easy evacuation is done. We can use syntostat drip later on once we have completed the evacuation. And then at that time, we can, if she needs anti-D prophylaxis, but she is 51 years old, but we are going into an era where we are making postmenopausal ladies into mothers also. So perhaps we have to keep that thing in mind also. We should not forget, yeah, she is 50 years, so we don't have to give her anti-D prophylaxis. Especially it's a partial molar pregnancy, then we have to give the anti-D prophylaxis. Incomplete molar pregnancy, we don't have to give. Then products of conception, should we send it for histopathological examination? 100% products of conception should be sent for the histopathological examination. Can we do cervix priming? Yes, with the prostaglandins, we are not advised, but at the time of operation, we can do the cervical priming. So if it's a, I think we will be discussing later on those cases when the uterus size is more, because at that time, medical termination is not advisable. Then what is the follow-up of these patients? That is very, very important.
Okay, can I interrupt a
Yes,
bit?
yes.
Okay, so you have said everything very correctly, very systematically. Now she has to be evacuated off the mode, and your choice was suction evacuation, isn't it?
Yes.
May I ask you this, for this patient, any other option for getting rid of this molds in this patient? Can we think of any other method?
Would you like to add on this?
Advisable to give the prostaglandins or mesoprost and
No, that is okay. Only for priming. We are not advising the medical abortion with the prostaglandins in molar pregnancy because there is a higher incidence of dissemination of the trophoblastic tissue.
Yes, yes.
So, but at the same time, the evacuation should be complete. Most of the cases now are diagnosed at an early stage, and incomplete abortion is the most difficult situation now. Now, when there is incomplete evacuation, there will be very high beta HCG going up. Unnecessarily, we will be starting chemotherapy. So, we must make sure that it is completely removed. For that, the priming is now with the prostaglandin, as you said correctly, is permissible. So 2 to 3 hours before your planned evacuation, you can prime the cervix. You can use the suction evacuation, as you correctly said, under guidance of the ultrasound to make sure that it is completely evacuated. Now, the procedure is done like that. Do you believe in prophylactic chemotherapy? Because she is a high-risk patient for GTN development because of the age and variety and other things. Do you believe in prophylactic chemotherapy?
FIGO has classified into
prophylactic chemotherapy.
Prophylactic chemotherapy, there is a controversy because they say if it's a complete
there's a controversy. There is a controversy.
Yes.
So which situation you may advise, if at all? So you don't believe, you believe in proper follow-up and picking up the GTN at the early stage and starting proper chemotherapy, not giving one shot and then sending the patient. So which patient finally, if at all there's a place, who is the patient who may require a prophylactic?
If it's already the beta HCG levels are very high, or the tumor size is more, or the uterine size is more than 20 weeks. So these are the patients which will be requiring the.
And those who are not going to come for a follow-up, even if it is a big size uterus, even if they are at elderly, if you think that because of the social factors, and socioeconomic condition, and from a remote area, if the patient is not likely to come for a regular follow-up and going to miss the patient, then there is a place, definite place. It reduces the incidence of choriocarcinoma or GTN, but it will never prevent it 100%. So if they develop a GTN, even after giving a prophylactic chemotherapy, that disease is going to be more resistant to chemotherapy. So that is why we do not routinely advocate, as you correctly said, prophylactic chemotherapy of one dose and then sending them. But in some situation, it may be necessary because this patient runs the risk of having 30 to 40% risk of having a GTN developing because of her age and parity. And if she is not at all going to come for your checkup and follow up, then at least give one injection or of methotrexate or actinomycin D, so that from 30 to 40% of risk is reduced to say 5 to 8%, which is a great thing. So in such situation, please try to give them something, not to let them. So I was asking, is there any other mode of treating this patient in the primary mode of treating the mole?
Dr. Shekharan, can I go ahead with
Sure. Only thing is they should give us.
I think this patient with a 50-year lady and diagnosed with a molar pregnancy, I'll prefer to go for the hysterectomy for this patient for two reasons. One, she's in very high risk for the GTN, and second reason also the 8 to 10 weeks pregnancy diagnosing as a molar is a bit difficult to differentiate from other malignancies also. So you will have a
molar pregnancy is the most easy thing to diagnose, but if it is
but that 8 to 10 weeks, you don't get a typical picture of the molar pregnancy, you know.
Okay.
Can I open?
So I prefer a hysterectomy for this patient rather than going for the evacuation.
Am I audible, sir? Can I speak?
Yes, sure. Carry on, sir.
Yes, no. What Dr. Maninder has answered is first option. You also added to that not only evacuation but a role of chemotherapy. But again, I would go to with this madam that hysterectomy should be discussed as an option to the patient, because as you say, the follow-up in our setup is very difficult. So whatever counseling, patient may not turn up. So better at 50 years with antecedent pregnancy more than 4 years, hysterectomy is one option. Always discuss with the patient.
Okay, that's right. So you have to have the preliminary investigation.
If we have to go for the counseling, then we have to tell her about the options. Of course, hysterectomy is one of those. She has completed.
As madam said, we have to have the basal investigation, complete hemogram if she is anemic, and arranging blood and other things. chest X-ray is optional, but it is better to have pre-evacuation chest X-ray, and also the renal and liver function test as a basal value can be done because they are good, but it's not a must. So that is the basic investigation that you said. We have diagnosed with the ultrasound. So suction evacuation is a very important thing, but make sure that it is completely evacuated. If it is under ultrasound guidance, you may be seen, so that the next bleeding may not be due to the incomplete evacuation. And the vesicles will just come out into the bottle if it is, say, easily you can get it out. And at the end of the evacuation, do a gentle curettage so that you make sure there is nothing remaining. Okay. And then if after 1 week, you must call every patient after an evacuation, call after one week, do an ultrasound and see that uterus is empty. If not, do a second curettage. So second curettage is done only if there's a doubt of anything remaining inside. Then subsequent development of the high level of SCG is due to GTN. It is not incomplete evacuation. Make sure that. So it is a must to call them after 1 week, do a repeat ultrasound, and if it is incomplete, do a scan and again DNC.
Should we
Okay.
do the beta HCG levels also at 7 days? 1 week?
That of course, that is there in the follow-up.
That is 7 days, 14
That is,
days.
I said after first week, the ultrasound to rule out its come. Then you have to keep on, and then you make a diagnosis, which you will come to. So hysterectomy was done in this particular patient. This is the specimen of the 50-year-old lady. We have done hysterectomy. We are told that we knew that she is not going to have a proper follow-up, and because she is 50-year and she was a bystander for her daughter who was admitted for delivery. She was as such embarrassed. She said, I will have the option of removing the. Even after hysterectomy, there is a hysterectomy will prevent invasive mole and other complications, but it will not prevent the choriocarcinoma developing later on. So even if you do a hysterectomy, she should be on a hormonal follow-up, I mean HCG follow-up. So thank you very much, Dr. Maninder, for the elaborate and very, yes, sir.
Sir, I want to ask you one question. You
Yeah.
said after 1 week sonography, then only check curative. Suppose sonography says it is complete evacuation, okay. But if there is bleeding, persistent bleeding, do you recommend check curative second week?
Persistent bleeding is due to two things. One is incomplete, most probably immediately after 1 week. Second thing is it is going for a GTN.
Okay.
There was a place for a curettage, and they said the incidence of chemotherapy after second curettage was proved to be less as per the UK study.
Okay.
But we don't
That's
believe
right.
in that. If we are sure that it is completely evacuated, if any further rise or if bleeding is severe, that is the chemotherapy is started there. Even if it is, you are not going to die. Severe bleeding, in spite of this thing, and slight rise in the SCG, we start chemotherapy.
Okay.
That is okay. That
Yes,
is the
yes.
thing. Okay, good. That's fine. Let's move on to the next one. This is to Dr. Uma Pante. Let me move this one from my screen. It is obstructing my screen. Okay. 21-year-old girl has molar evacuation, lost to follow-up after 2 months. She was coming for follow-up. She was not given any treatment. She thought, what is this? She went off. And she reports after 6 months of evacuation with the irregular vaginal bleeding. So this is the case. Madam Uma, please, can you help us how to proceed with this case?
Yes, sir. Thank you, sir. Thank you. And thank you, Dr. Jaydeep, sir, as well, for giving me this opportunity to be with you. This woman comes to us after 6 months of evacuation with irregular bleeding. She had molar evacuation of what gestation? I would like to know. Was it her first pregnancy? Because she is very young.
Yeah.
And then the most important thing in these types of cases is counseling. We must explain to them, counsel them that if they have a molar pregnancy, and then explain what is molar pregnancy, then we need to follow them up. We need to do the beta SCG level regularly. And if the beta, for at least 56 days.
Dr. Ma, can I supplement your counseling? 1 second. Because
Yes,
we have to counseling has to be in a very effective way, as you are stressing very much. Counseling,
Yes,
in the counsel, we must say that there's a chance of you are developing a cancer.
yes, sir.
Without frightening them. There's a chance of developing cancer. But if we follow up you properly, it can be 100% cured. and then you can have further childbearing. So that should be told. It's not frightening, but it's maybe slightly bit of the seriousness of the condition has to be told to the family that it may lead to a cancer. Unfortunately, we may have to use it. Otherwise, these people will leave in between and come at a later. Thank you, madam. That is to be very strongly and effectively and with the consciousness, we have to tell them that this is a situation like that, but 100% curable, so that they are not much worried. Okay, ma'am, continue.
Yes, I 100% agree to you. And I usually start with a sentence that this is one of the conditions in which if we give medication, it is totally curable. And therefore, if you just abide with the follow-ups, it would be good, and you will be perfectly healthy after that. So we should counsel this kind of molar evacuation women. And the good thing is that also in counseling, you could say if it's her young age and if it was her first pregnancy, and then there would be nice response. I would like to find out how much she's actually bleeding, and then is there vomiting? Is she primigravida?
She had
Are there
evacuation.
any
She
other
had the
symptoms?
evacuation. She had the evacuation. She
That I know, but was she primary when the evacuation was done? Was it her first?
She is a primary after evacuation. 6 months after the evacuation, she is coming with irregular bleeding. She thought there is nothing. She was coming for follow-up for almost 8 weeks. Now the problem is she has come with bleeding.
Yes,
it's
sir.
a molar evacuation history is there. There is evidence of evacuation is there. Now how to proceed?
Yes, sir. I understand that.
Yeah.
So if she is irregularly bleeding, that means the molar tissue is still there, and that's why perhaps she's bleeding. And therefore, we should ask the symptoms, other symptoms which molar pregnancy might present, which includes vomiting, dyspnea, neurological symptom. Then examine her. See the uterine size. How big is the uterus abdominally? Then you do speculum examination to see any the vaginal nodules are there. Many times the vaginal nodules only will bleed and bleeds. And then you would, if needed, you would also do internal examination. Then you would go ahead with investigations in the form of Dr. Maninder has already mentioned very well. And then you would go for a full blood count, serum beta HCG level measurement, then ultrasound, and if required, we'll go ahead with CT scan.
Okay, I'll give the value. I'll give the value. Beta HCG is 200 now. Beta HCG is 200.
Okay, very good. If beta HCG is 200, what does ultrasound show?
It is showing a bulky uterus, nothing specifically, no tumor tissue or a nodule could be seen. But the Doppler says there is increased vascularity onto some area.
Okay. And bleeding continues with
no,
clots.
It is only slight irregular bleeding, not heavy bleeding. At this point, what is your diagnosis? Okay. With this finding, what is your diagnosis now?
With the Doppler findings, you told me it could be an aneurysmal utero-ovarian artery or venous aneurysm could be there. It could be, if beta HCG is 200, that means there is pregnancy somewhere. And it could be still persistent there could be molar tissue there.
What is the diagnosis
so that would
now?
need treatment.
In this condition, what is the diagnosis? She is having positive beta HCG after 6 months of evacuation with a bulky uterus. Clinically, ultrasound also says, and there is a vascularity increase, can be a nodular thing, can be there. So what we have to put as the diagnosis in this case?
The persistent GTN?
Yeah, it is a GTN. Okay, yeah. It is a GTN. Now she has gone in for a GTN.
Yeah.
Okay. Now how to proceed further? I haven't thought that it is a GTN.
So you would, we do have serum beta HCG that is extremely low. And if we do the WHO
now the duration after the evacuation is important. The duration after evacuation is after 6 months.
Yes, that is there. I understand. Appreciate that.
Yeah.
So therefore, we'll do the scoring of the this GTN thing. And whichever score she falls in, we will start chemotherapy
so you have to do the metastatic study. Metastatic study you have to do. First is going for a chest X-ray. Okay. So you have to evaluate the spread of metastasis anywhere. If the chest X-ray is negative for any nodule, what is your advice then in that patient? Can you start treating her as a low risk GTN then?
If chest X-ray is negative and there aren't any neurological symptoms, there aren't any vaginal bleeding, there's no adnexal involvement, Yes, clinically it would be low risk and I would go for methotrexate. But if any of these, which
Now the chest X-ray shows a shadow. How to proceed?
what is the beta HCG level? Only
No,
200.
no, HCG level is there. It is there, say 200, 300, because it is after 3 months. It may
Yeah.
be 3,000 also. And the chest X-ray, one case it is negative. You will start treatment taking it as a low risk GTN after taking all the score. But if the chest X-ray shows a shadow, how to proceed further?
We have
Chest
done.
X-ray positive.
We would go ahead with CT scan for further investigation and find out what kind of lesion
Yes,
it is.
yes, good, good. That is it. If the chest X-ray is positive, CT scan of the abdomen for any liver mets, MRI of the brain. If
Yes,
the chest X-ray is negative, we need not go for any such extensive workout, especially in our country. So with the chest X-ray, with the beta HCG positive, which is not falling even after 6 months, you will make a diagnosis of GTN. Then the staging, for staging purpose, you have to study the metastatic sites and involvement. Then the risk scoring. And then after the risk scoring, we will go for all those things. So let us say, so HCG was done, ultrasound is taken again, chest X-ray was done. If it is positive, you go for all other things. You have to stage and score the patient. So the treatment decision to start single agent or multi-agent depends upon the stage and the risk score. If the stage is unfortunately poor by the MRI and CT abdomen and all, the liver and brain mets, then that is for multi-agent. If the risk score is 7 and above, naturally multi-agent. If it is less, you will start even in spite of the chest X-ray positive also, but nothing else is there. Still, that patient qualifies for a single agent therapy if the score is less. Okay, so that is how we have to go, and the scoring has to be done by the FIGO system, and we have to keep this paper if at all you are seeing anybody with your consultation room, so that you can score the patient properly. The failure of the treatment is. Pardon me? Yes,
I
ma'am.
have a point to make, sir.
Yes, please.
I would like to say that she went home at 2 months and now she's coming 6 months later and she is bleeding. We have to first of all rule out whether she became pregnant again.
Yes.
That is always a possibility.
Yes, sure.
And if she's pregnant and she's carrying, then we will just do evacuation. And if beta HCG is 200, then perhaps we are fine.
Yes, it can be even high with another pregnancy because she has gone home after 2 months. So that is the most important thing. And if it is a normal pregnancy continuing, no bleeding, what is our advice? She conceived within your follow-up period and she is having a normal pregnancy of 2 months. How to approach that patient?
I will just I will counsel her regarding
just because she is on the follow-up after a molar pregnancy doesn't mean that a normal pregnancy has to be evacuated. You have brought up a very, very, very valid point. So if she conceives spontaneously within this follow-up period, which you say she should have come for a regular follow-up, but within that time she conceived, and we have got the ultrasound now, and if the pregnancy is normal, let the pregnancy continue. You don't have to terminate that pregnancy which is normal. So very good point. Thank you, madam. It is very nice. You said every points and in this particular case. Thank you very much.
Dr. Shekharan, I would like to add something on that.
Yeah.
That's fine. It can be because of the next pregnancy, but in the cases where you have the gestation tuberculosis pneumoplasia in this case, where the level is less than 200 after 6 months, it can be placental site trophoblastic tumor. In such cases, if you consider for the management option for the placental site trophoblastic tumors, and when it is an other than that, the chemotherapy responsiveness to the PSTT is less as compared to the other GTNs.
Okay.
And in such cases, we may even think about going for the local surgical resection of this nodule because it is a high vascular. And if you do that, the response to the chemotherapy is much better and the results are better as compared to others.
Having made a diagnosis, usually they come with a regular bleeding. And if you do a DNC thinking that it is AUB, and if you are lucky, you will get the diagnosis on the curating that is the placental site trophoblastic tumor. If it is confined to the uterus, hysterectomy is the treatment. If she is not having, if it is resectable, there is an option, but there can be metastasis onto the uterus itself. A small nodule can be missed and it will grow. This is a very eminently curable condition if it is confined to the uterus. But usually they will come 2-3 years after the previous pregnancy event, mainly following a normal delivery. It can occur after partial mold. It can occur after a complete mold, as you said. So these possibilities are to be kept. Unfortunately, the diagnosis and those conditions will be missed because you may not get it in the curettings. You may not have the HCG, which is very high. Even though you will see a nodule on scan, then a low level of HCG and a small nodule on the uterus, still think of a possible placenta-site trophoblastic tumor confined to the uterus, then it is a very curable condition. If it spread outside the uterus, then it is very difficult to treat because chemotherapeutic response is very poor. So that's very good point. Again,
I'll just further add, even if you do the hysteroscopic resection, that should be patient should be kept on the follow-up and will be started with the chemotherapy also. That is very vulnerable point, I think. Because many a times they do the hysteroscopic resection, don't send for histopathology, or they don't keep them on the follow-ups also.
Should be done. That is the purpose of telling everyone that these patients are curable. They are young, mainly when they are coming. So we have to be careful. Let's move on to next because we are taking more time. I think this is to Dr. Anshu Raina, a 30-year-old lady with a history of 2 cesarean section earlier was followed up after molar evacuation though there was steady fall of HCG. It was 20,000 international unit per liter after 4 weeks of evacuation. Seeing that high level, she was advised to have chemotherapy, but did not get admitted as her sister was getting married. This is the actual case. These are all actual case. And because she was to go for her sister's marriage, she didn't said she will come after that in spite of telling her. But she reports after 2 weeks to the casualty in a state of shock. The vaginal bleeding was not massive to account for the shock. So what's your diagnosis and how to proceed with this? Dr. Anshu, please. Anshu. Okay, sorry.
Yeah. This excellent panel, and thank you to Jaideep sir and the whole organizing team.
You are not very audible. You are not very audible. Can you be close to the mic?
Yes, better, sir.
You are not very audible. Can you be more close to the your device, computer or phone?
Better now, sir.
Yes, now you can. Yes.
Yeah.
Carry on.
Thank you, sir, and thank you to Jaideep sir and the whole organizing team to giving me this opportunity to as a part of this panel. What I am seeing is she's 30 years lady with history of 2 cesarean section. At this stage, I would just like to know how long back the cesarean section, the last cesarean was done. How many months or year back the last cesarean was done in this particular case?
3 years back, and second cesarean was done 3 years back. I don't know.
Back.
She had she was diagnosed as a mole after missing the period, and she had an evacuation. She was on regular follow-up, and the HCG was even at 4th week was 20,000.
Yes.
What is your option? We advise her to undergo chemotherapy because this patient may be at a risk of other complications. That's why you advise.
This particular patient, she is 30 years lady with history of 2 normal cesarean section, and this time the molar evacuation was done, and she was under follow-up even after the 4 weeks of just 4 weeks period. The beta HCG level was 20,000, so it was alarming, and she was advised for the chemo, but she refused and she went off, and then again she reported in shock. So this whole scenario is going more towards the post-molar gestational trophoblastic neoplasia.
What exactly resulted in shock?
But the reason of shock, just within 2 weeks of period is really a shocking thing. That going to
this is the right time, sir. This is the right time to present with intraperitoneal hemorrhage and it's a perforating mole. So this is the right time. They present.
Actually,
it's not unusual. It's unusual.
Yes.
This is
okay. Thank you, Dr. Bhagyalakshmi, for adding on to that. This patient, we have to do something immediately.
So
I said the vaginal bleeding was not profuse,
that's what
but
I'm
she
trying to say, sir. In this particular patient, even without a very less amount of vaginal bleeding, she came in shock in just 2 weeks period gestation. So very likely there
no
is
no
an
not
internal
two
hemorrhage.
weeks. She is on the follow up.
No, no, sir.
She lost
When
follow
she
up
came in shock, that is after just after 2 weeks of her the last when she came in.
last visit. Yes,
Yes.
afterward
So
last
that's
visit.
what
Yes,
I'm trying to
true,
say.
true, true.
And just 2 weeks period. So first thing will be in my mind to see there should not be any internal hemorrhage, although the vaginal bleeding is very less. So that doesn't indicate that there will be no internal hemorrhage. So after the basic reset, because she came in shock, so basic resuscitation and shifting to the ICU unit, my first aim will be to know the what is her ultrasounds, to know in ultrasound to see the uterine size and the internal hemorrhage, and the
It
simultaneously.
is all hazy. It is all hazy. Abdominal cavity clinically also having fluid collection. So then, what? How to proceed?
So that itself is showing that the internal hemorrhage happens because of the invasive.
Because we have to know it is a possibility of the perforation of the uterus by the invasive mode.
Invasive mode.
Especially this, that is what we also anticipated in this particular patient. This is the actual case what we are dealt
So
with.
because of the invasive wound, she bled, and after that she went into a shock. So that the main that investigation of the, apart from the baseline investigation of shock patient, that is definitely the blood counts and everything. So first of all,
That is all
I would like
simultaneously.
to,
That will be done simultaneously. Immediately, what will you do? We are eager.
so now,
Patient is in shock. Yeah. Yes, ma'am.
yeah, in this particular patient we will start with the after the scoring system and all. I would like
No
to
scoring is possible. No
This is
scoring is
a
possible. She is
you
in
have
a
to
very dire state of a
stop the
shock.
bleeding
she is
urgently.
in shock. We will definitely take a patient after stabilizing the patient. We will take her for the laparotomy.
Yes.
And
So don't waste any
Yes.
time. She had an evacuation done. She was on follow-up. She had the report of 20,000 just 2 weeks back. She was also tell you that if somebody will there, she will tell us we were advised. So with all this background, think of internal hemorrhage due to perforation of the uterus and decide on laparotomy immediately. You cannot wait for even a ultrasound finding. You will see clinically maybe massive hemochromatosis can be diagnosed. So don't waste the time. You think of this. So you have to keep in mind this is the possibility perforation of the uterus by an invasive mode and severe intraperitoneal bleed, which warrants immediate thing. Even if she is not having children, sometimes you may not be able to save the uterus, but we have done. So this is what has happened. You see, can you see?
Yes.
This was a massive perforation. We could not put the clamp anywhere. She was bleeding profusely and internally, and there were the abdominal cavity was full of blood. And we could somehow do a subtotal hysterectomy because it was all friable tissue. You can see the lateral side on either side. The clamp was coming off. So friable tissue, which was all perforation, and we did something like a subtotal. I'll put it that way only. That is all at that time. She was given 8 or 10 units of blood, and then we started on chemotherapy, single agent only, as per that staging. And she was complete remission minus the uterus. Probably we could have saved the uterus by starting the chemotherapy at least at that point, which we missed. At least one course could have been over, and by the time the shrinkage of the mass will take place, the vascularity will come down. So this is one case which we will keep it in mind whenever somebody is on follow-up and she is having any evidence of bleeding. Think, especially with a high beta HCG, think of invasive. Thank you, Anshu, for that whole contribution. Thank you very much. So this is what we want to know, that we have to think of this very rare possibility. Now, Dr. Sarita Agrawal, how will you diagnose GTN after molar evacuation?
I think it is very well discussed earlier also so many points, and we come to know that the beta HCG remains the mainstay and the follow-up. So as soon as we do the molar evacuation, we have to advise for the follow-up where the beta HCG measurement is advised weekly or once in 2 weeks. And if there is a rising level of the beta HCG, that's more than 10% for the 3 readings, or if there's a plateau level for more than less than 10% decrease in next 4 readings, such cases should be confirmed as a GTN. And the second thing, and next thing, if it is a histopathological diagnosis, come to be a choriocarcinoma, then stays it is GTN. Apart from that, I think it has been discussed that a patient should be done a careful history should be taken regarding the symptoms for the distant metastasis like the lung mets, hemoptysis, and dyspnea, for neurological symptoms like seizures, for the CNS metastasis, which is quite common.
So it
And of
becomes
course,
a diagnosis on the marker. If
yeah,
there is a plateauing of the level, which means a less than 10% fall compared to the previous week, which is for 4 values over a 3 weeks time.
yes.
That itself is diagnosing GTN. We don't have any tissue diagnosis. You don't have any radiological evidence of any malignancy, but we take it as a GTN.
Yes, the
Then we
FIGO
go for
says the
once you
three
diagnose GTN.
criteria.
Yeah, yeah.
These are the
Yes.
three criteria as for the FIGO for
You,
conforming for GTN. That is
yeah,
3 values uh, rising or the 4 values which is at plateau.
yeah,
And that is in so on that base we can confirm the GTN. And of course, most of the time we send the tissue for the histopathological after the evacuation.
yeah,
And
yeah.
if the HPR says it is a choriocarcinoma, so that confirms the diagnosis of GTN. And now
Then
coming
you
to
go
the
for the metastatic workup, as we said, chest X-ray, if
yeah
it is
metastat
possible, CT
yeah
abdomen, CT MRI brain, and then stage the disease. You go for with that chart
I'm
for
coming
the
to
scoring.
I'm
Yeah,
coming to
yeah,
that.
yeah,
So this has been already discussed. Beta HCG. Then based upon this beta HCG level, you go for the further metastatic follow-up. That is
yeah,
X-ray chest followed by CT chest and MRI brain and liver and abdomen.
yeah,
And based upon that, the next step is that you have to make a staging of the disease. Which stages belong to? When we know the stage 1, 2, and 3, do you want me to elaborate? I think that will take time but not required. In 1, it is confined to the uterus, and then 2, it is confined to the like pelvis, and then 3, when the lung mets are there, and 4, when the distant mets are there.
yeah.
And then at the same time, we have to do a scoring, which is very, very important to decide if we are going to go for the single agent therapy or the multi-agent therapy. So that a scoring chart, I think Dr. Shekharan, you have already shown, which includes the 8 factors to be looked for. That includes the age of the patient. Second is the antecedent pregnancy, which what was it, molar or it was a normal pregnancy. And then we look for the index pregnancy duration, for how long after that index pregnancy is presenting. Then you have to look for the size of the metastasis. You have to look for the size of the metastasis. And then you have to look for the number of the metastasis. And then you have to review whether she has taken the previous chemotherapy or not. Based upon that, we do the scoring. And the score comes to be less than, it is less 6 or less. That is the lowest GTN. If it is 7 or more, then it is in high risk scoring, high risk GTN. And in all cases where the lowest GTN are there, the treatment recommended by the FIGO and the other societies are the single agent therapy. And for the more score more than 7, we have to go for the multi-agent therapy. So
What is our choice of a single agent?
yeah, about the single agent therapy, you have the choices between methotrexate and actinomycin D, but then methotrexate found to be less toxic as compared to the actinomycin D. So I'll prefer to go for the methotrexate therapy.
Okay.
And then in methotrexate also you have various options. You can go with the methotrexate with the folinic acid rescue regimes, or you can go for the only methotrexate regimes. So still, I will prefer to go for the methotrexate with the folinic acid rescue regime because it is having with the less toxic, more compliant by the patient.
Right. That's it. So low risk case are grouped, diagnosed, and then start with single agent. Actinomycin is also equally or better effective, but we are convenient. I mean, comfortable with the methotrexate, more
Because
experience with methotrexate.
yes, actinomycin has a more toxicity and the patient compliance is not as good as with the methotrexate actually.
At this juncture, I will tell, just to remind you all, if the actinomycin has to be given, it must be given very safely after starting an IV drip. Let the line be going properly. Then onto that you can inject. If you extravasate the actinomycin D, it will cause local sloughing and severe pain. If at all it happens with we usually give instruction to juniors, you give it, and there it may happen extravasate. And if at all that happens, immediately infiltrate the local area with 1% silocaine 1 ml and 100 milligram of the hydrocortisone, so that the local reaction can be. If at all that complication occurs, so you have to be careful in these drugs as such. So thank you very much, Dr.
Sir, I just want to add one more important point, which is usually missed by many of the obstetrician and the like. Once you give a methotrexate therapy or whatever therapy you give, once the P beta RCG level comes to be normal, the consolidation phase should never be missed. Otherwise, the relapse can always.
How many courses? How many courses?
That is the 6 courses are recommended as per the.
After it has become negative, for consolidation, how many courses more we have to give?
The FIGO says it. I think it is 6 weeks only.
Okay, 3. Single agent 2 or 3. It is okay.
I had also the same impression, but I just gone through the literature, which is sent by you only, I think, and it is mentioned the consolidation phases for 6 weeks for all type of chemotherapy.
Yes, it has.
The article shared by you, it is there, that thing only that I came to know by this article only.
Yeah.
I was also thinking it is 3 weeks only, 2 to 3 weeks, but this article says for 6 weeks, irrespective of whatever agent.
Yeah. That is 3 courses are to be given to prevent any recurrence of that thing after having a cure. Because even if you say beta HCG negative, say to produce 1 unit of beta HCG, there must be 10,000 cells. So even if it is less than 1, there may be some cells circulating. That is why we have to give it even after HCG has become negative. You should continue with the consolidation therapy. Make sure that she's,
Another reason for the consolidation therapy, most of the labs are not measuring all the types of beta HCG, which is there in the circulation, and then you can get a false impression of a normal beta HCG level, while the other subgroups of HCG may be there in the circulation. It's not being measured by your labs.
Okay, we are going to two more presentations. So
sir, sir, with your permission, 1 point only. Because of giving this methotrexate folinic acid regimen, sir, the commonest regimen which is followed most of the part of India is day 8 and a day 6 gap. But the problem which we face that what they do is they give 8-day cycle and then repeat the cycle after 15 days of the day.
No. 1 more week. 1 week. After 1 week.
Kindly clarify that for all our.
It's good. Every 2 weeks. Every 2 weeks the course. Before starting every course, please repeat the complete count. LFT, RFT. The drug of methotrexate is detoxified in the liver and excreted by the kidney. So kidney and liver has to be normal to give methotrexate. So before starting every course, do the complete count and LFT, RFT. So every 2 weeks the course is repeated. That is the course. Not after completion, then another 2 weeks, then effectiveness of the drug will go.
I just want to elaborate, Dr.
Malignant cell, it should not come up.
Sorry to interrupt, so there are only 2 minutes remaining for the panel.
We have got 2 more presentation. So please let me go to the other people.
Yes, sir. Yes, sir. No problem.
So this is what we said. Anyway, Siemens Emulite is the thing which will pick up all. So next is to Professor Bhagyalakshmi, that at 36-year-old lady, para 3 follow up after molar evacuation, diagnosed at low risk GTN. She was given 4 courses of methotrexate folic acid with a good response, but did not complete the treatment and returns after 4 months. She didn't continue with that thing. And with the vaginal bleeding, cough, general weakness, anemic, uterus 14 weeks, chest X-ray, multiple opacities management, diagnosis management. This was a patient who was responding well. Since she didn't have any symptoms, she left. So this is the problem. In our country, this is the problem. Okay.
Sir, when they come back, actually we have to stage them and score them again. So it's a dynamic scoring. We have to score them again.
Stage them, score them again. She was a low risk case. Don't start again another single agent. This patient requires a further rescoring and restaging by proper investigation like MRI, CT, and everything, and rescore, and then decide which treatment. That is the only point I want you to say. This patient has to have a restaging and rescoring, and then most probably she will require multi-agent therapy as per the score. So that is the most important thing in this particular case. They may go, you diagnose it as a first, low risk GTN, started on single agent, she was responding, but now comes with a spread down to other parts. So staging and rescoring and then deciding on the thing. So you may just say multi-agent. Okay, probably. Okay, ma'am. Because that is the most important point.
Yes, sir.
Restaging and then multi-agent therapy most probably she will require. We will not go on to the multi-agent therapy because the organizers are to start again. They are sending messages. So, Bhagilakshmi madam, anything else to add as an important point?
No, sir. No, sir. You have summarized everything. We have to do all the investigation, meta-HCG, everything, score her again, and then plan the management.
Yeah. That is accordingly you have to give multi-agent most probably. Metastatic workup, CT abdomen, MRI, risk scoring and restaging. That is the summary of this case, and then decide on it. I think slide is not to be seen. Okay, this is to Professor Harish Doshi. A patient at 3 months amenorrhea, uterus 14-16 weeks. USG shows molar tissue and a baby. Diagnosis and management, sir.
Sir, you have said the USG shows molar tissue and baby. Diagnosis is there. If you are in doubt, you can go repeat sonography.
What is your diagnosis?
Partial mole.
Okay, 90% it could be partial mole. It could be
Or
something
rarely
else.
it can be between pregnancy and one mole and one that if you have not done
partial mole, what will you do, sir, if it is partial mole?
Partial mole, my first counseling will be first
counseling we said you will evacuate, isn't it?
You will evacuate, yes, that is there.
Okay, but if it is twin pregnancy and a mole,
then also I will counsel about the complication of this, and also that is the first line of treatment. But in both this partial mole or a twin pregnancy, the baby can be normal. All partial mole cannot be deployed.
Excuse me, sir.
Yes.
If it is partial mole, it is a triploidy.
Yes, but
and
all
the babies can have abnormality. Once we diagnose partial mole, get rid of that pregnancy. So it is not again coming back as a complete.
You are right. You are right. There are cases reported in the literature that you go for amniocentesis and go for this karyotyping. If it is diploid or digynic type of triploidy, then there are less chances. But again, you have to counsel. I told you the first answer is termination. Management is termination. But if the patient is keen and you are not mentioned the age, primary we will say 35 years of age.
Any wanted pregnancy, if it is possible to get a baby, we have to give that baby. We don't have any right to terminate. Okay.
Right. Not
once you are sure about what my point was different. Once you are sure that it's a partial mole, there will be abnormalities on the baby. Let the partial mole be evacuated. If you suspect that it keeps a twin pregnancy and a normal looking baby, go further to repeated ultrasound, including 3D ultrasound. As you said correctly, find out that the baby is normal by even going for an amniocentesis and karyotyping. Then allow the pregnancy to continue. Rightly said that you have to counsel for the complications like bleeding at any time, termination at any time because of the bleeding,
and all structural
oxygen developing. You said all those complications can come at any time. So with that, in spite of all these complications that you have mentioned, 50 to 60% of them can go to term and have a normal baby also.
Yes.
So that is the point you are telling. Even amniocentesis you are willing to do because it is a wanted pregnancy, wanted baby, you don't have any right to remove that. So partial mole out. But you are having doubt that, it looks like the molar tissue is somewhere, that there's a normal looking placenta and there's a normal looking baby with a amniotic sac there. Go for repeated 3D ultrasound. And amniocentesis very correctly said, make sure the baby is normal, then allow the pregnancy with the complication they are going to take.
Yes, in literature, there are cases reported that they have been survivable babies have been born.
Okay, let us see what happened to our patient. This is our patient. Okay, you can see on the top part, this is a 3D image. You can see top part is the normal looking placenta. This is the molar tissue. This is the baby. We had several views of this and it was looking normal. We counseled as you said. We did the amniocentesis also as you said. Okay. And she carried on to term. This is the 3D finding of the normal looking placenta, molar tissue. Okay. We did everything. And this was the result. So you don't have to throw away. So this is again our patient. In this case, The molar tissue has undergone degeneration, luckily for us. After some time, the beta HCG was not going up. It has static. She never developed any preeclampsia. These patients are likely to develop preeclampsia at earliest. They are likely to have repeated bleeding. In our patient, she never had any bleeding. And we did a PV at 39 weeks. She delivered the same night. The baby came, the normal placenta came, and we have to remove this molar tissue degenerated. It was molar tissue only. We had the follow-up. She had the follow-up, and 1.5 years after this, she had conceived and delivered by cesarean section for fetal distress. So again, she came to us. So these pregnancies are to be differentiated whether it is normal. Another condition that can have a baby and a molar-like tissue is the placental mesenchymal disorders. We have that case also. So differential diagnosis of a molar-like tissue with a baby, one is partial mole, where there will be focal changes. There will not be any very normal looking baby may look normal, but it may be having triploid.
Beta will not be that high.
Yeah. So that itself may not differentiate, but again, you go for repeated. If you are having doubt that it may be a normal looking baby with a normal looking placenta, and the normal looking placenta is not having a molar change any of the area, so you have to really scan and sit with the sonologist. If you are not doing, you have to tell them this is the situation and other things, and then go for amnion. Thank you very much, sir. Very good, very good. I think
your case was a normal looking placenta. It was a twin molar.
Yeah.
No.
It was one mole, one twin pregnancy. No.
Molar tissue with baby. Molar tissue with baby. So it can be partial mole.
Partial, he is saying because the placenta was absolutely normal looking placenta.
This is not a partial mole. This is a twin pregnancy. This is a twin pregnancy, one normal and one is molar tissue. One of the twin has undergone molar change, complete mole. It was complete mole. Okay. So this is not part of that placenta. The placenta is entirely separate. The pregnancy sac was separate. The baby was looking normal. And we had the karyotype beforehand. So this is a good outcome. So there are chances of such thing with a complication of up to 50% complication can occur in these cases. So every case need not be treated. So baby with mole can be salvageable if it is normal twin pregnancy. Salvageable. Okay. Thank you very much, sir, for that. All the points you have said. I think we must thank the organizer. We have taken overshoot of time. Thank you very much. Thank you, Ansha, Dr. Sarita, and of course, Harish is my close friend. Of course, very good. And thank you very much, Dr. Bhagyalakshmi, for guiding us in between. You should have been moderating. I should have been sitting here. Very good.
No, sir, I have enjoyed a little bit.
Okay. Dr. Maninder, very good. Thank you very much for your elaborate contribution on the first case where we covered almost everything. Subsequent cases, it was easy to continue with the discussion. Thank you all.
Thank you.
Roshan, we are stopping. Don't say we have overshoot very much.
Basically, I'll just insist again that counseling of the patient for very important at every stage. That is the main thing. And we can carry out to normal with the without chemotherapy, just with the follow-up also.
That is what I said. You may have to tell the word cancer. You may have to tell them that there is a possibility of a cancer. Unfortunately, we have to say that.
Percentages at the extremes of the age have to be counseled with the patients.
Okay, Dr. Maninder, we had 98% regular follow-up of our 1,700 cases because of the proper counseling. So we are not claiming anything, but that is important to say that it can be curable. Okay, thank you, Roshan. We are out. Thank you, everyone.
I think, Anshu, do you want to make a
one more important thing is whenever the patient is coming with the recurrent episode of bleeding after evacuation, in the second evacuation itself, we must send the histopath examination to rule out in a normal MTP cases also if they are coming repeatedly with the bleeding PV and going for the evacuation.
I'll take half a minute or more because Dr. Anshu has brought out a very important point. We are not doing routine histopathological examination. My request to all of you will be any pregnancy termination, whether it is MTP or otherwise, please check the urine HCG after 1 month. it should be negative. If it is positive, it is something else. So that is the other way of looking at it. Even if you are not sending for histopathology of every abortion, every MTPs and other things, please do a check of urine HCG after 1 month. It should never be there after a normal pregnancy. If it is there, you have to see that it can be dropped away. Thank you very much. Right.
Sir, at least the repeated abortions have to be sent for biopsy. If you are
It
doing
should be.
yes, sir.
In a situation we are not doing, at least do the urine check. That is what I said. Since we are not doing routinely, please do a very simple thing at least. If it is positive, it is not normal. That's my plea.
RCOG 2020 recommends even after the medical abortion, you should do an SCG level after 3 weeks.
Yes, that's very true, very true.
Any abortion, because they had a series after MTP, they had 4 or 5 cases of choriocarcinoma after so many years. That is a publication by Michael Seckel from Charing Cross. So that is why in our situation, even if we are not able to do the histopathology, please do a SCG. This is for all my delegates. Please do a SCG, I mean urine pregnancy test after 1 month. They say 3 weeks. In the Green Top 2020, they say 3 weeks. Okay, the same people were there in that FIGO guideline also. There we haven't specified it, but please do a HCG urine after 1 month of any pregnancy evacuation. If the patient after delivery develops irregular bleeding for 5-6 weeks, please do a urine pregnancy test because it could be something going on. So thank you. We have to get out. Thank you very much.
Thank you, sir. That was quite a fascinating discussion. I'm sure all of you will agree. And you realize how fascinating it was because when we started, we had around 2,000 live users. And at the end of this panel discussion, we have something like 2,655 live users. So not only have people not left this panel discussion, but more people have joined. Thank you very much, Dr. P.K. Shekharan sir, and all the wonderful panelists for the quite lovely inputs. We have a short video now, but before we go to the video, Rohan, please allow me to thank the moderator and the panelists of the next session so that post video you can seamlessly take over. And I would really like to thank Pragya over here for readily agreeing despite her hectic and very busy schedules. And Pragya, you have really the pleasure of having some wonderful panelists for your panel. There is, of course, Dr. Pardesi, again, someone who I believe is like a mentor to me. And his enthusiasm for ultrasound really has to be seen to be believed. There's Dr. Mandakini Pradhan, another very capable committee chair. Dr. Sita Pal. Sita, besides your academic achievements, I can tell you one of your bigger achievements is telling Bhaskar not to speak anything. So congratulations on that. And then of course there is Meenu, our very, very capable and enthusiastic committee chair for the imaging sciences, and Dr. Luna Pant and Dr. Prashant Acharya. I have known both since a long time, and I've known Prashant Bhai also since such a long time. We have not always agreed, but I believe we have always respected each other a lot. Thank you, Prashant Bhai, for being here, and that's quite a lovely background you are using in your image. So thank you again very much for the panel which has just happened and the panel which is about to happen. Rohan, over to you.
This can hide wherever you are sitting. Your background remains same.
Rohan. Yeah, thank you so much, Adiswa. Before we move on to the next panel, we'd obviously like to thank our educational partner, Torrent Pharma. I think they have a small video to play right now. Maruti, is the video ready? I think there might be a little bit of a delay in that.
So Rohan, please proceed with the panel, then we can play the video later.
All right, sir, not a problem, sir. So I think we'll move on to the next panel, and it gives me a great pleasure to introduce the moderator, Dr. Pragya Mishra, ma'am. She is the immediate past chairperson of the Genetic and Fetal Medicine Committee of FOXY. She's also the treasurer of the National ISOPAR from 2017 until date. Our panelists are Dr. Rajendra Singh Pardesi. He was the Vice President of Foxy 2019 and is currently the Vice President of Amox 2020. Dr. Prashant Acharya, sir, he's the Vice President of Foxy 2012, and he's also a ISUOG board member and ambassador. Dr. Mandagini Pradhan, she's the professor and HOD from the Department of Maternal and Reproductive Health, Lucknow, and she's the chairperson of the Genetics and Fetal Medicine of Foxy. Dr. Sita Pal, ma'am, she's the managing committee member of the Bengal OBGY Society, honorary treasurer of the Society of Fetal Medicine. Dr. Meenu Agarwal, she's the chairperson of the Foxy Imaging Science Committee, the executive board member of the International Society of Gynec Endoscopy. And last but not least, Dr. Luna Pant, ma'am, she's the president of the Dehradun OBGY Society, and she's also the director and HOD of the Max Super Specialty Hospital, Dehradun. Over to you, Pragya Mishra, ma'am, for your panel.
Yeah. So Rohan, I'll start sharing my screen.
Yes, ma'am, please.
Yeah. Okay. Yeah. A very good evening to all of you. First of all, I congratulate Dr. Jaideep Tank for having come up with this innovative idea of holding a series of educational events, which he calls it O2S. And I believe we are going to have 70, and really, all the gynacs in the country are really going to benefit by all these, programs that we are going to have. And also thank him and his team for giving me the opportunity to moderate this panel on modern prenatal testing in pregnancy. And to have, well, in the last 2 decades, we have seen a lot of advancements in prenatal testing and diagnosis. With the advent of new biochemical markers and advancements in technology, and with better USG machines with greater resolutions, and of course the expertise of people like who are our esteemed panelists today. Like we have actually this the branch has really grown by leaps and bounds these days now. So modern prenatal testing in pregnancies, actually it has become an integral part of our pregnancy care. So Rohan just introduced, but just to let you know that we have stalwarts in fetal medicine from the country, like Dr. Prashant Acharya and Dr. Mandakini Pradhan for this panel, and we have stalwarts in imaging, like imaging science, which are Dr. Rajendra Singh Pardesi, Dr. Sita Ramamurthy Pal, Dr. Meenu Agarwal, and Dr. Luna Pant. So I think we will have a wonderful discussion with all of you. So, and these are just, cases, quite common cases, which, you all come across in your day-to-day practice, and quite straightforward, but, sometimes the general obstetrician, you do get calls, because they have some confusion regarding the reports and all that. So we can, Sita, I couldn't see you. I think you are there, right?
Very much, yeah, very much.
Yeah, okay.
Thank you.
So I think we can start with you, Sita.
Okay.
Yeah. So Mrs. A.V., she's 28 years old, and just one second. I was wondering whether I've unmuted myself. So, right?
No, we can hear you clearly. Yeah.
Yeah. Okay. So Mrs. A.V., she's 28 years old, gravida 4, para 1. She has had 2 miscarriages and she has 1 living child. In her first trimester screen, basically, with the serum markers like PAP-A and beta-HCG, you can see the levels. PAP-A is low, which is 0.110 mom, and beta-HCG is 0.270 multiples of the median. And the uterine artery PI is 0.510. So actually, they have given, based on just serum biochemistry, they have given a very high risk of trisomy 18, which is 1 in 10, and the risk of trisomy 13 is 1 in 116. As you can see that both PAP-A and serum beta-HCG are quite low in this case. So the question is, what next? I mean, those people have just given the results based on the serum markers. So Sita, like in your practice, and especially, you're probably, well, you've done your fellowship also from RCOG, RCR, of imaging. Now, I'm sure that, next, you would like to look for all these, secondary markers and all that, isn't it?
Yes, true. So if you go back, I would start from the beginning. First of all, thank you to Dr. Jaideep and Dr. Parishik for involving in this O2S series and let me share this platform with such doyens of fetal medicine. Now, as you go back, you see you have to start from the history. Like, I would like to know what her two miscarriages were, what duration was, anything, whether there was any abnormality or what anything was there. And secondly, if she's had an FTS, what were the findings on the ultrasound scan? What was the NT like? Though you have mentioned that the NT was normal, I presume, but was there anything else? Was anything else done now, since we know that
No,
we have?
I haven't mentioned yet that NT was normal. What I'm saying that the lab, just gave the report that based on serum biochemistry, this is the report, that
So
there's a high risk of trisomy.
this risk was only on the biochemical markers, not on the NT.
Yeah, so that's what. So next step would be that, you would be looking for NT and nasal bone and tricuspid flow and all these things, isn't it? So you would be going for these secondary markers, right? So, and based on that, now the next step, I mean, then the lab also gave the report. Now they're saying that, combining all this, now the risk of, trisomy 18 and risk of trisomy 13 is not so low, as you can see in the picture. Now here the question is, that's why where I was heading towards, it was like, like normally in your practice, suppose if, it was actually a very high risk, in the first trimester, depending on even on NT and nasal bone and tricuspid flow and ductus venosus, if they did give a high risk, then what would you do? Like, would you be going for a contingent screening? Like in the first
No,
trimester, see if the risk was very high.
we have to be first very clear that when we look for aneuploidy screening in the first trimester, we do a scan. We look at whatever, if it's ideally possible, to look at, because the scan is the basic essential more than the biomarker. So if you look at the scan, look at the NT, if everything looks okay, and then you put in the biomarkers, we get an estimate. Now, for, as we say, usually for trisomy 18 or 13, because gross abnormalities can be picked up on ultrasound. So whatever we see on the ultrasound, we can predict whether this baby is going to be at high risk for trisomy 18 or 13 before the biochemical markers do come. But for trisomy 21, it may not be the same. But any risk of, and if especially if the NT is high, or if there are other markers in the first trimester, like the ductus venosus or tricuspid regurgitation, for whatever reason, if they are there, or if the markers are high, then if the risk is pretty high for trisomy 18 and 13, we wouldn't go for any contingent screening, especially if it's very high. We would go in directly for an invasive screening. That is, the risk is more than 1 in 100 or so if we are combining with the other markers. But if it is,
so basically with contingent, we divide it into, high risk, intermediate risk, and low risk. As you can see in this, this I've got from that, from Nicoloidis, that his article was there on turning the pyramid of antenatal care. That's where, he mentions.
In the for Fetal Medicine Foundation, if you add in the other markers like the ductus venosus and tricuspid, that your cutoff for your high risk for invasive further decreases down, because the basic aim of adding these the other markers is to decrease the risk number of invasives.
Yeah. So that's what. So double marker.
So I'm still not quite clear what the exact risk was here, actually. So,
on combining all this, NT plus nasal bone, etc., her age, this is actually just from the lab report, which they have given. And it's an accredited laboratory. And that's what, and it was done in Bangalore. So, and this is the report that they gave. Anyhow, so it was basically, the whole aim over here is, now, so if like aneuploidy screen is actually, normal for her, if she's not a high risk, so what can low PAPE predict? This is what, I just wanted our attendees to know, that if somebody has low PAPE, what could you predict based on that? Or what would you do after that? say aneuploidy screen is fine, it's not a low risk. I mean, it's not a high risk. Then
Do you want me to answer that? Or?
yeah, just low PAPE, quickly, just low PAPE.
Yeah, so basically low PAPE. PAPE is basically produced by the placenta, and it is a marker for placental insufficiency. So, any PAPE low markers can predict aneuploidy or fetal growth restriction or increased incidence of preeclampsia or hypertensive disorders in the pregnancy. So a trisomy aneuploidy fetus usually has a low PAPE, and combined, we have to look at the moms rather than the absolute values. When we look at the moms and, combined with other features, then we have an estimate of what this baby is or the mother is at risk of developing things later in the pregnancy.
So basically the message to the audience that you would like to give is that, we should also, in spite of the fact that if the lab gives a low risk of aneuploidy, but, if the PAPE mom is low, then, we have to be quite vigilant with these.
So anything less than 0.4 is considered as low, and we take that into account, and depending on that, we call her for a
as you know, in this case, as I showed you, that it was actually the PAPE was 0.110 mom. That's what they were giving.
Okay.
Yeah. So maternal markers are vital for the screening of chromosomal disorders and structural abnormalities, but recent research indicates that maternal marker parameters can also assist in the prediction of other complications such as preeclampsia, preterm birth, and as you mentioned, fetal growth restriction, etc. So now the thing is, of course, I mean, you would be you would be going for growth scans to assess interval growth and like a volume and Doppler in view of low PAPE. And, I would come to this preeclampsia screening in the next case in more details now. So now in this patient, now because, she was quite apprehensive, although there was no need for an NIPT, she went for an NIPT, and NIPT mentions that, all the aneuploidy risks are all actually, she belongs to that low risk category with aneuploidy. So 21, 18, and 13 and all that. Although truly there was no need for that, but, the patient wanted an NIPT, so she went for that. Now, later on in the pregnancy, at about 17 weeks on level 2 scan, there was one minute echogenic foci in the right ventricle and two minute echogenic foci in the left ventricle. But the extended cardiac survey was normal. So what next? So here you have a patient who's initially on FTS, she had a low PAPE, and then, but her NIPT, because, she insisted that was normal. So to quite an extent, we have ruled out aneuploidy. But then again, you find these foci on ultrasound scan. So basically, what next then? So would you just reassure her? Would you just reassure her that all is good, or or would you like to do something else?
I think we should rule 18, right?
Yeah. I mean, the other panelists are also most welcome to join. It's not that, only I started off with Sita, but then, you can also give your opinion. But we have 6 cases, so we just want everybody to be quite precise, so that, everything gets covered. Okay. So here actually, because, I mean, I think once chromosomal studies are also normal, like, her based on first trimester screening and NIPT, I mean, of course, we all know that low PAPE and low beta HCG may be associated with adverse outcome in a few cases. So, but what this lady needs is a regular ultrasound to assess interval growth, like a volume and Dopplers. That's what we would recommend for her. I mean, we would tell her as far as, aneuploidy is concerned, she need not worry about it, but then we have to be more vigilant as far as this pregnancy is concerned. Any of the panelists, quickly, would you like to? I mean, Sita has already mentioned everything. So I was just trying to say that, the lab actually, on all the gynecologists may not have the facility. They would just get the report as, serum markers. So what is important that, they should ask, or they should refer the patient to a sonologist who is like, is an expert in fetal medicine and, who can look up for the other markers so that, the lab can finally give the accurate rate for the risk of aneuploidy. So because others, normally they just get, they just give the double marker report as they had done in this case initially, then later on asking, then they compiled together and gave the report finally.
Let me tell you, Dr. Pragya.
Yeah,
As
yeah.
far as your first case is concerned, it's about ultrasound is first always. It gives you such a more precise information. These biochemical markers, they are going to die in couple of years because they have got very less sensitivity as far as trisomies are concerned. You have got far more better test, what is known as self-repeated DNA or NIPT, which is coming at 5,000 to 6,000 rupees now. And your biochemical markers are costing 2,500, which is with a zero, 60% of sensitivity, which has got no value. And as far as your PAPE is concerned, you have to think in a line. If it is around 0.4 mom, please think about preeclampsia screening. If it is 0.1 mom, that is severely low, you should think about the placental dysfunction. There is no question of trisomy 18 at that point. So you have to be very sure at what level your PAPE is. So it's 0.1, you are looking at a pathetic placenta. 0.4, 0.5, you are looking at a possible trisomy and also a possible preeclampsia screening later on, or development of FGR and PIH later on. So you have to look at a level of PAPE and then think about the pathology, and don't give a primary importance to biochemical markers. Give primary importance to your ultrasound. Read that, make them understand about what your ultrasound is saying, rather than asking them to learn about biochemical markers plus or minus. So that's what my opinion, and that's what the world is going towards. So we don't have to work till what was done before a decade. You have to think about what people are doing and what is going to be the next. This is the next step, and think about that.
So one message that you would like to give now that, with the reducing cost of NIPT, because, until quite recently it was 25,000,
No,
30,000. Now it's gone down.
Last 5,000. Now 5,000 rupees. If you want to get it done, send me. I will get it done in 5,000 bucks. No worry.
Yeah, well, recently they did come to me saying that they have reduced the cost, but I think it's not that cost is not available to everybody. So
it's everyone. Everyone. It's available to everyone. So make sure.
And second thing that you would like to highlight is that, that always focus on, the PAPE values. If they're very low, like, you really have to be vigilant about these pregnancies, that because, she may be heading towards complications future on in pregnancy. Right. So these two things you would like to convey. And of course, where you have fetal medicine experts, really, they would be going for all this, first, like, NT and nasal bone and tricuspid flow and ductus venosus flow. They would be concentrating more, on the ultrasound parameters rather than, but the combined first trimester screening, it means NT plus these two biochemical markers. So now we'll move on to the second case, and she's a doctor, herself, and she's gravida 2, para 0. She had one miscarriage, and she books at 11 weeks, and she's heard of this enhanced FTS, first trimester scan. Now, what are the components of enhanced, to Dr. Meenu Agarwal, what are the components of enhanced first trimester screening? And is it like easily available? Do you do it in all patients, or do you do it in just patients with a specific history?
See, normally we can do a combined test wherein we do a double marker test along with the anti-scan, right? That is a combined test. In some cases where you want to do enhanced scan with either by one of the fetal medicine people or by one of the FMF specialists. So if you have a good anti-scan report along with a good double marker, I think that serves the purpose. But you can definitely also do a GL PF or other test as well along with this. Yeah, it is possible.
Oh. So other tests would be like, you would be going for uterine artery.
GL PF, yes, yeah.
Yeah, so you try natriuretic PI and mean arterial blood pressure. Okay, sometimes, like people have asked, so normally in the prescription, the blood pressure is mentioned, so they can calculate from that, and you can tell the sonologist to, apart from NT, to specifically look for natriuretic PI as well.
Yes, yes. Along with, of course, you take the MAP of the patient, family history, previous history. In this case, she has no history of PIH in the previous pregnancy. But yes, you can include that. That is because we know that PIH is more common than aneuploidy. So we should actually screen more for PIH than for aneuploidy. So that is an important screening that we must look at for these patients, for every patient.
So what is the cutoff risk that you use?
Can I just add something?
Yeah, sure.
I just wanted to say that enhanced FTS adds 2 more markers, the AFP and the PLGF.
Very good. Yeah, very good.
It doesn't, it only marginally increases. It's the same as the usual FTS, PAPI with beta HCG. The only additional factor we have is the PLGF. So if you measure it along with the mean arterial pressure
and alpha-fetoprotein as well,
then no, for the PLGF and uterine artery PI, it will give you a risk for preeclampsia. And the AFP, of course, it can give you for open spinal bifida, open neural tube defects, but that can be obviously seen on ultrasound. So a good ultrasound can pick up all those things. So there's only a marginal advantage we get by having these other 2 markers. The PLGF, of course, has a role in predicting preeclampsia. That's what.
Okay. So what is the cutoff risk that you use for preeclampsia before 37 weeks and before 34 weeks for screen positive result? I mean, what would you say? Like, 1 in how much that you would
1 in 100. 1 in 100.
Exactly. Yeah. So, but yeah, in this patient, I mean, they actually gave a low risk of preeclampsia before 34 weeks and before 37 weeks, which they gave, it was 1 in 4,000 and 1 in 455. That's the risk that they gave. I mean, this is how, that an enhanced first trimester screening report was done with beta HCG, alpha-fetoprotein, PLGF, NT, PAPE, mean arterial pressure, and uterine artery PI. Sure, Dr. Acharya, I would, yeah.
This is when you are getting your PLGF done, you can utilize your 1:100 cutoff. That's fine. Okay. Whenever every center or every patient, you don't ask for PLGF.
Correct.
Right. Majority of 99.9% of the patient, you are not asking for PLGF. When you don't ask for PLGF, your risk cutoff has to be 1:150 or 1:200, because the value which PLGF gives you, you are trying to cover those patients by increasing your limit. You cover more patients because you are not offering them PLGF. So these are the patients where you can give them benefit by lowering your threshold and give them aspirin 150 milligram at bedtime. If you're not offering at PLGF, then rather than 1:100, you put your cutoff at 1:150. So that mean mean arterial pressure, uterine artery Doppler, and maternal offset, her characteristic and a past history will give you an idea what is if she is having high risk or not. So that's how you have to do it if there is no PLGF.
So some of the laboratories, the accredited laboratories, they are offering this enhanced first trimester screening, where they are actually, apart from beta HCG and PAPE, they're adding PLGF to it. Alpha-fetoprotein.
I totally agree. When you ask for PLGF with alpha-fetoprotein and inhibin A, actually a part is also inhibin also. And if you are talking about extended, the cost goes so high that rather than do ultrasound, offer them NIPT, because these things, your ultrasound will take care of MAP, uterine artery Doppler, past obstetric characteristic and past history, and NIPT will give you far more accurate result as far as PIH or PET is concerned, as well as aneuploidy is concerned. Why you want to make the entire pregnancy complicated? You should make it as simple as possible. Good ultrasound, a good NIPT will solve all your problems. Why you want to make it more complicated? Whenever you are talking about offering this prenatal screening to mass, it has to be simple. You don't have to have more than 2, 3, 5, 7, 8 factors so that you create more complicated pregnancy. Make them simple, make them cost effective. Whatever I'm offering has to be cost effective if I'm talking about screening. Right. So that's what my personal opinion. Make it simple rather than complicated.
So just for the benefit of the audience, what is enhanced FTS? Enhanced FTS is a new first trimester screening test that uses 4 serum markers plus the nuchal translucency measurement along with maternal age. And it is to generate a pregnancy specific risk for chromosomal abnormalities in the baby, risk of the baby having an open neural tube defect, risk of having preeclampsia during the course of pregnancy, possibility of having a small of fetal growth restriction, and the 2 new serum markers that are analyzed include placental growth factor and first trimester alpha fetoprotein, in addition to PAPA and free beta HCG. Now, the thing is that by including the 2 new markers, enhanced FTS is an improvement over FTS, and it has been shown to have a detection rate that is comparable to integrated prenatal screening of about 90%. And positive screen result, they can further, as you know, they can further evaluate the risk with NIPT or confirm the chromosomal abnormality by diagnostic invasive testing. And in addition, it gives a risk estimate of preeclampsia and fetal growth restriction, which can be avoided to a certain extent by prescribing tablet aspirin 150 milligrams to the mother. So, and the proposed surveillance strategies in these patients, if any of the panelists would like to, in a case where, we were just talking about, what would you do in cases where, enhanced FTS shows that, she's at a high risk of preeclampsia, then, we would go for all these monitoring, like maternal home blood pressure monitoring, then regular measurements of urine protein to screen for preeclampsia, and second trimester Doppler studies at 22 to 24 weeks, regular ultrasound evaluation of fetal growth and placental morphology, then interval non-stress test and biophysical profile for fetal well-being, and for select patients, MRI of placenta to rule out accreta, percreta, increta. So that's what we would do. So this was just, a paper which was published in the PubMed, and which was about enhanced first trimester screening for trisomy 21 with contingent cell-free fetal DNA. So in that, study, they concluded that enhanced FTS with contingent cell-free DNA following a positive result provides a similar performance to that of primary cell-free DNA testing at a substantially lower cost. This was a paper which was published in the PubMed. So we'll move on to the third case. Dr. Pardesi, I would like you to take up this very simple case now. So Mrs. SP, she's 37 years old. She booked in late at 21 weeks. A quadruple marker test showed a posterior risk of Downs of 1 in 607. So, yeah. So basically, now I just wanted to ask you that actually I can't see him in the grid. I just wanted to ask you, that, but what do you think? Does quadruple marker still have a place in modern prenatal testing? Or Dr. Pardesi or any of the panelists can answer?
Can I answer?
Yeah, sure. Dr. Luna, yes.
Actually, I wanted to add to the enhanced prenatal, the first trimester screening also. It is not very expensive because at max, it costs 4,000 rupees to the patient, which is much lower than the NIPT costs. Of course, NIPT has a higher sensitivity. And the advantage is that, like you said, trisomy 21, in 89 to 90% of cases, they will be positive. In this case, the third case, quadruple test, yes, it does have a back place now. Now with the combined testing, quadruple test has a back seat. It has taken a back seat, but there are certain patients who come in late who may have
like this patient, she booked in at
At that stage, this definitely has an has a place. And of course, combined with a level 2 ultrasound. And here we do all the 4 tests, the alpha fetoprotein, HCG, the unconjugated estriol, inhibin A. And yes, this is these are the justifications that when
as you just mentioned, where it's not available, where it's not readily accessible, or diagnostic testing for women with an FTS positive result or is not accessible and readily available. So then, you have no choice and you have to offer a quadruple test.
In certain remote areas where we may not be having very expert sonologists, In that place, labs are available, labs are accessible, you know. So, and there are people who collect samples at other places. So this is easily available. So there is a place still.
Yeah. Especially in this lockdown period, we had many patients who missed out on the first
Yeah,
trimester
very
screening.
true.
So they came in only.
We will.
Yes, very true.
I have a case
Choice
like
but to
that
do a
also.
second.
Pragya, just to inform you that Dr. Pardesi is there. I think he's trying to speak, but I'm unable to hear him.
Oh, has he not unmuted himself?
No, he has. Sir, if you could remove your headphones and speak, that might be useful. You can just remove the jack from the laptop.
Oh, maybe the volume is low. Sir,
hello.
Yeah.
Hello?
We can hear you.
Yes, sir, we can hear.
If the genetic sonogram in this case is normal, we can give options of NIPT. That it is.
But you know, this patient, I mean, okay, fine.
And if soft markers are present, then we can offer invasive testing also.
That's it. Yes.
And
Why
quadruple marker, as Pragna told.
You are actually, because Dr. Pardesi, you're a clever man, I know. And, you know, this in this, the lab actually, although, you know, the quadruple marker test showed the risk of Downs as 1 in 607, which is not a very high risk. It's an intermediate risk.
It's an intermediate.
Yeah.
Yes.
Yeah, and you know, but what they are saying, you know, in the notes, that in view of equivocal or intermediate risk, which you know, further testing through the following options should be considered, and in that, you know, they have mentioned about NIPT, and the definitive testing, invasive testing as well. So I was actually in two minds that because she has a risk of 1 in 607, does she really need any further testing? But because, you know, once the lab gives you some sort of indication, then you want that, you know, you might as well go ahead and do it. So, well, these are the components of a quadruple marker test. And then ultimately, you know, what happened? Okay, so in your, that was my question, which, well, we all answered, that in this case, where the risk is 1 in 607, would you just reassure her or go for further testing? Now, perhaps I would have reassured her, but because in your practice, what is the cutoff risk for Down syndrome in quadruple marker test above which you would go for further testing in your practice? Normally, what is the cutoff that you use?
See, in these cases, we will go for the NIPT, and if the soft markers are present, then we will give the option of invasive testing. In this case,
so you are just even with the value so this is important, because you know why I'm saying, because you know, most of us in quadruple marker screening, we have the cutoff of 1 in 250, or in some countries they use the cutoff of 1 in 270. So specifically, you know, I was wondering, you know, with 1 in 607, like, you know, Dr. Pardesi is saying that, you know, he would still go for an NIPT or for an invasive testing. So I actually, you know, I wouldn't have thought about it, but then because her age was 37, so I thought, you know, the two put together, this intermediate risk and age above, you know, so I did go for an invasive, and actually, to my surprise, you know, found that, you know, she was a case of trisomy 21. This patient, but forget about this report. What about my other esteemed panelists? Would you actually recommend invasive testing or NIPT at an intermediate risk of 1 in 607?
Can I come in?
Yeah, sure.
Dr.
But
Mandakini.
actually, you know, because I can only see 4 people, you know, on my
doesn't matter.
Yeah.
What I can add on is a patient who has got a quadruple test because of any other reason should have a good ultrasound examination.
Yeah.
And that should includes the soft marker. And that includes ARSA, that is aberrant right subclavian artery, and a measurement of nasal bone, apart from rest of all those soft markers. And if I'm looking at the ARSA and the nasal bone, both of them are normal and rest, all soft marker are absent, then her risk becomes 10 times less. So a report of 1 in 607 becomes 1 in 6007. So then in that case, she falls onto a low risk and you need not do any invasive testing. If any of the soft marker is present, as Dr. Pardesi rightly said, then your risk of 1 in 600 increases to say 1 in 100 or so, and then in that case you opt for the patient is offered a invasive testing. So it depends on the likelihood ratio of the marker, and for all practical purpose, if there are 2 markers or more than 2 markers, then that will definitely fall onto a risk which will indicate a invasive testing. So more than 2 markers, invasive testing.
Put together that level, that cutoff of 1 in 607, along with the
ultrasound findings.
It's just that
and then
Dr.
you
Mandakini,
recalculate your age.
All the gynecologists may not have the privilege of having Mandakini Pradhan or Prashantacharya in the town, so they will have to manage with that 1 in 607. So that is the problem. And I was actually surprised when Dr. Pardesi said that with 1 in 607, he would go for invasive testing or NIPT. Normally, because I've, I was trained in England, and there, above 200, 1 in 250, if the risk was, less than that, they wouldn't actually go for invasive testing or NIPT. Yeah, yes, Dr. Acharya, you want to say something, and and Sita also wants to say something.
I totally agree with Dr. Mandakini that anyone who is offering ultrasound will be able to see the nasal bone. I may not expect them to look for ARSA, but if you see the ventriculomegaly, they are going to measure the posterior ventricle. They will be able to see the nasal bone. And if all the soft markers are negative, then whatever risk you are having 607 will be reduced by 5.5 times. So it will go to 3,000 plus. So she becomes low risk. No ultrasound markers. You see, whether should I do invasive testing or what should I offer eventually is decided on the all markers when you complete, and then what is the risk which has come down. It's not only on one marker that you have done quadruple marker, so that's fine. No, it doesn't work that way. You have to add the ultrasound. If you are doing only ultrasound, if you find something intermediate, go for better. Then you may offer them quadruple marker. If they can afford, go ask them to go for NIPT. So, but if they want 99%, if they are okay with 99% assurance, if couple wants, no, I want everything 100%, then you can't offer them quadruple marker or NIPT. You have to go for you have to go for invasive testing. So it's about, you have to combine everything. Epidemiology screening is not about one thing.
Yeah. So along with this level, you need someone to do a good level 2 scan.
So
And
every city, I can tell you, India, in every India major city, you have got good people doing good scan. At least looking for these markers.
Yes.
Dr.
Prashant.
If somebody is able to do amniocentesis, it is expected that that person will be a good ultrasonologist.
Yes, of course. Then and then you should perform amnio.
Okay.
Dr.
You want to say something?
Counseling is very important.
Absolutely. Yeah. I just wanted to add, I agree completely with Dr. Acharya and Dr. Pradhan. But the other thing I wanted to add here is it depends on the gestational age. If your patient was at 21 weeks and you find these, an NIPT is going to be very dicey because you're going to lose time there in getting the results. And if again it comes positive, you'll have to go in for an invasive testing, and that's, you don't have that much time in hand. So if your ultrasound is absolutely fine, your risk is low. If your ultrasound has any markers, you will directly go in for invasive. These are the only 2 options here at this gestational age, especially nearing around 20 weeks.
See, Dr. Sita is correct. Even Prashant is correct. But in the metro cities, or all if facilities are available, so we can give them choices. But as Pragna told you, what is the role of quadruple marker? But I am telling you, still in 50% of area, when taluka level, quadruple marker is really helpful because they can club the result and contagion screening. And Prashant is very right. Everybody should do at least nakal transfusion and combine all the results. So hence the role of quadruple marker is really essential all over. But if chance comes in metro cities where the facilities are there, so we can offer them the all other tests.
Absolutely.
Also, I think if you're in the first trimester, if your risk is then you go for the quadruple marker. So that is also a possibility of a quadruple marker where you can do it.
So, and apart from aneuploidy risk, what other adverse outcome can the components of quadruple marker test predict? So there was a paper published in the Obstetrician and Gynecologist by the RCOG. It was on maternal serum analytes as markers of adverse obstetric outcome. So it's not just for aneuploidy, they can also, they are also markers of adverse obstetric outcome, like, preterm birth and preeclampsia, fetal growth restriction, etc. So, and there was another, yeah. So there was another article where the ability of the quadruple test to predict adverse perinatal outcomes in a high-risk obstetric population, which also highlighted, the benefits of the maternal serum analytes. So as you can see that, if the alpha fetoprotein is raised, then, there can be it can be associated with FGR, fetal death, and there's a whole list, with the raised alpha fetoprotein, raised HCG, and reduced unconjugated estriol, increased dimeric inhibin A. So these are the associated complications, with the, so it's very, so quadruple marker, one of the big benefits is that, these analytes throw a lot of light on, what the pregnancy is going to be like, and you can actually, strictly be quite vigilant about these women, in the follow-up. So we'll move on to this
one
case.
study, just hello,
Yeah.
just
Yeah.
add to that, even one study suggestive of E3 is estimates to add to diagnosis of congenital adrenal hyperplasia.
Yes.
Okay.
Even duodenal ectasia, Fallot's tetrad, and
Yes.
Turner syndrome, it can diagnose these as well.
Yeah, I mean, Turner's, I mean,
Some studies have shown that it can diagnose these conditions as well.
Yeah.
There is an article. Yeah.
Sure.
Continue.
Yeah. No,
Okay,
you say first. You first.
No, the other helpfulness of the serum markers is very well documented in that Green Journal article, and it says that which marker at what gestation and what should you do to that pregnancy, so that there are markers which predict early fetal death. In those patients, you follow them up closely. So the table at the end of that article is very, very helpful in your routine day-to-day practice, and everybody can put it and then follow it.
Yeah. So, so the message to the audience would be that, when you're looking at a quadruple test, even if, so be quite, look at the actual marker levels, what they have given. And because based on that, you will know, you can actually predict a lot of pregnancy complications. So that's another advantage of the quadruple marker test. Now, this was, just to throw light that now this was another case where, this patient, Mrs. RK, who's 34 years old, came at 16 weeks gestation. Her quadruple marker test showed a risk of Down syndrome of 1 in 134, which is a relatively high risk, compared to our last patient. Now, in this one, would you go for NIPT or invasive testing, and why? So, I mean, of course, from the discussion that we've had, and if the cost of NIPT has gone down, I think a lot of us would be opting for NIPT with this report. But I don't know, some of our esteemed panelists would still say that, because NIPT is still a screening test and not a diagnostic test, you would still go for an invasive testing.
Again, it depends on the ultrasound, isn't it? At 16 weeks, if you can do a genetic sonogram sort, and we can see there is nothing else, and then you discuss the options with the couple, because she's 16 weeks, we have time in hand. We could go in for an NIPT if they want to, but if they want 100% confirmation, then we would do an invasive testing. I would just like to take an opportunity to tell this, that if for screening, we have to do only first trimester or quadruple. The triple test has to be thrown out of the window.
Yeah. No, we are not doing triple test.
Because still in many places, people are doing the triple test.
Yeah. This we have, emphasized on different platforms, but still, you do get prescriptions with a triple test and all that. So, why these two cases, they were based, and now this patient's amnio report showed it was normal. in this patient. So basically here, just to highlight that, a patient who is at a low risk does not mean that she will be negative for aneuploidy, and someone with a high risk does not mean that she will be positive, for aneuploidy. And why I'm, saying this, because I have seen, patients where, the history has shown that because, the triple, believe me, in some of the peripheral places where they have, just because the risk has come as high, they've gone ahead and terminated the pregnancy. And I think none of you would disagree on that front. This happens in real,
This
in
goes
real
hand in
time.
hand with Sita again here, and I would like to stress that yes, definitely, because she was only 16 weeks, definitely one should go for NIPT first and not for the invasive, because there is a small risk of an abortion, even because of the amniocentesis. And as a senior, it came out as normal.
Okay.
Another
So,
counseling and counseling.
Yeah.
Of course,
So Sita, you want to say something?
Dr. Acharya also wants to say something. I'll let him speak
Please,
first.
please. I will ask Dr. Sita to go first. Ladies first, always.
No, thank you. No, I would slightly disagree with you, Dr. Pant, in that respect. It all again depends on what the ultrasound shows. If there's any the likelihood ratio increases with any marker, or if there's any gross abnormality, then NIPT is a no-no, and we would go. So, we have to actually go by what the ultrasound shows. And the risk of miscarriage is actually very, very low than what is, it's less
I
than
agree with you. Only if there were no ultrasound markers, soft markers. No
and regarding the risk also of
Exactly.
amniocentesis, the recent data shows that the risk is very, very low, less than 0.5% in fact. So.
I would like to comment about the risk factor. 1 out of 167 means how much? It is 1 out of 100. 1 out of 100 is 1%. This is 167 is less than a percent.
No,
So
this
the moment
is 1 in 134.
134 is about 0.8%.
Yeah.
That means 99.2% these fetus is chromosomally normal. You got it? So the moment you counsel, if you convert into percentage, it makes the life of the patient very easy. Even if the risk is 1 in 50, the percentage is how much? 2%. 98% that fetus is still normal. So if you want to make your patient's life easy, convert into the percentage. You are nowhere wrong at all. That will make your patient's life easy. 1 out of 10 is 10%, still 90% chances of normal. So you have to counsel them accordingly. It will make the patient's life so easy. Then what you have to tell that even if it is 1:10, it is 10%. Now what my counseling is, now there are 10% chances of chromosomal abnormal baby and there are 90% chances of normal fetus. If you want to investigate whether you are in 10% or you are in 90%, you have got two options. 99% surety NIPT, where that's the charge. It will take 2 weeks time, and these are the advantages and this is the disadvantage. If you want 100%, I have to offer you invasive testing. That's the charge, that's the complication, and that's the outcome. Let the couple decide rather than I decide on them. That's how the ideal scenario has to be. Non-directive counseling, offer them. You don't take the risk. You don't take the decision that this is what you are supposed to do it. No way. That is how you have to do it clinically.
Right. Can I add something, Pragya?
Please.
Yeah, sure.
All right. Another thing, what is for the delegates, that whenever we are doing this double marker and quadruple marker, we must tell the patient before doing the test that it is just a statistical data which will tell us in which risk group you are falling, whether you are in 0.01% risk, and you may need to go for further testing if required. So I have had patients where they were in high risk and they said, we do not want to test, we do not want to do amniocentesis, we are okay. So that means even if we had not tested her, they were fine. They did not want to go further testing. So that counseling is very important before we write down, go for double marker, quadruple marker, or whatever, NIPT.
Dr. Prashant is right, because legally also, you just tell them, you don't take decision. You see, 90% you are going to normal. Just tell them. That is the most important in this era of Consumer Protection Act and all other.
Always couple has to decide, not we.
Exactly,
We can only
exactly.
put the
If
cards
we
on the
will,
table, you choose the
exactly.
card.
If we will tell them, then they will catch us.
Right.
Doctor, आपने ही बोला था.
Right.
Like this.
Absolutely, absolutely. Totally agree with
So the message here is that before you go for any, screening test, counseling is very important, which, in a busy clinical practice, we forget. We
Even
forget
if
to
you,
counsel our patients.
even if you are doing only ultrasound, at the end of your ultrasound report, make it mention a line. This ultrasound will give you 89% risk for possible detection rate of trisomies. If you want to improve your detection of trisomies, NIPT will give you 99%. Or adding biochemical marker will add 2% to whatever 90%, whatever ultrasound has given. Put it in black and white. So tomorrow they should not tell you that in newspaper you may be reading that I was offered only ultrasound and now baby is trisomy 21. You are supposed to pay compensation. I
Yes,
have
right.
written, if you want it better, go for this test. Put a line there in the report. That's how I'm doing. I'm doing today in my practice. I put one line. These ultrasound will give you 92% because I'm doing my NT-NB-DV, TR, and that's how I detect 92%. Then I write, if you want to add 2% more, adding biochemical marker will give you 94%. Doing NIPT will give you 99%. Doing invasive testing will give you 100% with it, but it carries risk. There is one disclaimer which is written always.
Yeah.
So you should not take responsibilities of whatever you are doing. That's always correct.
Okay. So now we'll move on to this next case where Mrs. NK, 29 years old, primary gravida, FTS. This was the report. Only biochemistry showed a high risk of aneuploidy. Now I got this bizarre sort of report where they are saying that the risk of Downs is 1 in 91, of Edwards, which is trisomy 18, is 1 in 69, and of trisomy 13, which is Patau's, is 1 in 69. Now, this sort of a report I got. And this patient, I mean, as you can see, from the prenatal first trimester, only biochemistry screening summary, that's what they have given. This was the report. Now, this patient did not turn up for the report nor for consultation due to lockdown, because she was in her first trimester in the month of March. Then, of course, then lockdown came, and then she did not turn up. She turned up at 26 weeks in the month of June. So there, the a USG was arranged, which showed a gestational age of 24 weeks, Leica less than adequate, AFI of 6.7 centimeters, no congenital anomaly detected. Now, we've been talking about, that looking for all these, ultrasound markers, and then you would say that, especially the ones who are very good at scanning, they would go by that. But now see, in spite of the fact that, her report was saying that she has a high risk of aneuploidy, her ultrasound is saying no congenital anomaly detected. Now what next? Now she's already, 26 weeks. And well, you have to consider the scenario of our country also. If it was UK where, there's no limit, it was a different thing. Now, so what next now? So now Dr. Acharya, would you like to answer this question? Now, this patient, she did not, poor patient, she did not turn up. She actually underwent a first trimester screen, but then she didn't turn up until 26 weeks for a report. So now
what I will do is I'll do a detailed scanning. I would try and do the uterine artery Doppler. I would try and find out what is the cause for a little less Leica. AFI 6.7 at 24 weeks, you can't measure AFI at 24 weeks. It has to be single largest vertical pocket. Let me be very clear about that part first. If it is less Leica, I will try and see for the renal cause. I'll try and look for the preeclampsia or hypertension and a uterine artery Doppler. If that is fine, her kidneys are normal, I would also rule out some of the infections. So Leica part is ruled out. I look for the anomalies, and if there are no malformations, at the end, then I'll do nothing. What my job is, now at 26 weeks, there is no role of any aneuploidy screening methods, whether it's an NIPT or whether it is quadruple marker or anything else. Screening is not possible. So if they want to, couple wants to know exactly then I have got only chondrosynthesis with me. I'll perform chondrosynthesis if couple wants to have precise diagnosis for trisomy 13, 18, 21. Because that complicated report of 13, 18, 21, everything high, which is very rare, I tell you, that is the point. Because the combination of markers, they are so, either there is 13, 18 or there is 21, which is going to be high.
I'm
In
sure
this
some
case,
of you would have seen reports like this, you know.
that's what I'm saying. That may not be, I will not go with the report because there are more chances that that report is not correct. It may be false positive. There are more 30% chances that report is false positive. You have not done ultrasound. This is only FTS which has got 60% sensitivity. 40% that report chances are wrong. I will not go, I'll give a damn to that report. I will not give any damn to that report. So for me, it's ultrasound, 26-week ultrasound. My counseling, if they want 100%, I'll go for invasive. Otherwise, I ask them, forget about it, leave it just like that.
In any case,
Dr. Mandakini Pradhan, Dr.
Dr. Luna wanted to chip in.
I just wanted to say, in any case, since we cannot terminate pregnancy after 20 weeks and even after 24 weeks, even if there's permission from the court, so there's no point in doing any invasive procedure or NIPT. It's not going to give us any additional.
I tell you one thing.
The management is concerned. So
I tell you one thing.
Monitoring.
I tell you one thing. My job is to do the diagnosis, because it will probably help them in making their obstetric decisions. If it's a baby of Down syndrome and the baby has gone for cephalopelvic disproportion, then rather than doing a cesarean section, they will wait and still they will deliver a vaginal delivery. If something goes wrong with the baby, still I am not hampering the obstetric career.
Yeah.
Right. So my job is to do the diagnosis. As a prenatal specialist, that's what my job is.
Ultrasound monitoring and managing the pregnancy further. I would feel of course, counseling is important. Counseling the patient is very important.
And we should
I fully agree with Dr. Prashant.
Just
that
one
you need
last
to
case is very important, you know, just finishing very quickly. Yeah.
Okay, Dr. Pragya is hard pressed. This is I go with Dr. Prashant and we can jump forward to the next case. Dr. Pragya, please.
Yeah. So basically, everyone would like to go for USG monitoring in this case. Now, but you know, this patient, you know, she wanted to be very honest, like, of course, USG monitoring. But then, you know, but because of this bizarre report, I was also a bit, you know, hesitant, you know, that, you know, to just leave her like that, and did go for an NIPT where, you know, you can see the red dot and it says, you know, she has a high risk of, you know, Turner syndrome. That's what, you know,
I would request you never ever send a patient to this lab, because you can't offer them NIPT after 22 weeks. No question. NIPT at 25 weeks. There is no question.
Okay.
There is no question about doing NIPT 25 weeks.
Okay. The sad part was that after a few weeks, in spite of all that ultrasound monitoring and you know, and admission and rest and empirical treatment, the baby actually died in utero, and the baby, and it was a confirmed case of you know, Turner syndrome, so this was, you know, the story of this patient, where, you know, we got all these bizarre reports of trisomy 18 high risk, trisomy 13, and trisomy 21. But ultimately, what was found that this patient had the baby had Turner syndrome and the baby died. You know, of course, if not for the lockdown, perhaps, you know, this thing could have been, well, I mean, it would have been sorted out much earlier in the first trimester, but because the patient didn't turn up, so that was the sad part of this patient. And just, you know, I'll quickly, you know, go on to this last case where, you know, a 29-year-old under 5 para 4 presented to the obstetrician at 8 weeks gestation. There was a history of spinal muscular atrophy in 2 of her children. So what next?
What next is spinal muscular atrophy.
I would like you to take up this case quickly.
Yeah, spinal muscular atrophy is the autosomal recessive condition. That means that it has got a 25% risk of recurrence. So if anyone who has got a previous history of child being affected with SMA, here 2 children were affected with SMA, we should offer earliest is 12 weeks CVS chorionic villus sampling, so that the sample can be tested, sent to the lab for spinal muscular atrophy. Along with this, we can counsel the couple that the same sample can be stored if the fetus is normal. Then further testing like chromosomal anomalies that we were discussing about Downs and all can be tested on that same sample. So these two things can simultaneously be done. First is SMA testing, CVS to be done at 12 weeks, sample to be sent to the lab for mutation analysis for spinal muscular atrophy.
Okay, so basically this is because it is an autosomal recessive disorder, and if both parents are carriers, then there is there's a 25% chance of the baby being normal, 25% of the baby chances of the baby being affected, and 50% chance of the baby being a carrier. So now the thing is, okay, so fetal DNA analysis was done for this patient was actually referred, to somewhere to a tertiary level center in Delhi, and then fetal DNA analysis was done for spinal muscular atrophy, and the report came back as this amniotic fluid DNA does not have the homozygous deletion in exon 7 of SMN1 gene. The couple was reassured. I do understand that the obstetrician must have sent the patient on an earlier gestation. What happened, I don't know. But, this test was carried out, actually at 34 weeks there. So this was a surprise for me, that carrying out this test at such an advanced gestation, what Dr. Mandakini Pradhan told us, that would have been ideal, going for a chorionic villus sampling, or you have earlier on, or if you've missed it, then go for amnio. But here, I was surprised that, in a quite a reputed center, and they did the test at 34 weeks. They could have left the test.
Now doing so many programs, so we know that we have to help each other. But I think she comes for once in a while, so she thinks help nahi kare to chalega.
Okay, I think somebody is not muted the.
Oh,
Priyanka, please mute yourself.
Yeah. So can you, can you just this last thing I would like to ask? Can you justify invasive testing in such advanced pregnancy? I mean, at what gestation, Dr. Mandakini has already answered, but can you justify? If it was UK, yes, you could have. But, like Dr. Acharya was earlier of the impression that, you can do it at any stage, as
that could be there can be justification in doing a test in that advanced gestation. Dr. Prasant Acharya already have highlighted that it may make or change your mode of delivery, so that you avoid a operative delivery on an affected pregnancy. So that way you can save the future pregnancy outcome. So that could be one of this thing. Second is, sometimes the parents are very, very anxious to know whether the fetus is normal or not once they know that there is a high risk. So sometimes with parents' consent, after a lot of counseling, still they would like to know it. But for all general practice, the same tests are done from the blood collected at the time of delivery from the cord. So cord blood collected in a EDTA vial can be sent to the lab for the same test. Okay.
So no.
Dr. Mandakini is right. We can avoid C-sections for the affected baby.
So justification is to
exactly
the mode and to decide the mode and the place of delivery.
Exactly.
Not really for diagnosis, but it looks,
also.
Yeah, again, the invasive testing is not only for termination; it is also to prepare the couple and the obstetrician as to what they are going to, be facing.
Last case. And next thing, in intrauterine gene therapy, so as to avoid the consequences. Of course, the therapy tested on mice, it is in the now laboratory phase, but we can consider this gene therapy, intrauterine gene therapy.
Okay, no, but what I'm saying that if if it was done in a place like Patna, there they would have said, oh, the obstetrician doesn't know, or why she did it, and she had probably termination in her mind. But because it was done in a place like Delhi, no one would say that they would say
don't underestimate Patna.
Dr.
And
Pragya, let me tell you.
but it happens, that it's just like, Patna, Delhi, Mumbai, and then New York, it's like that.
No.
Someone was just saying.
It is not like that. Whenever patients comes to you, you have to mention in the report, in your prescription, patient came for the first time, and that's the why I have carried out the test at this time. Entire controversy will be settled, whether you are in Patna or you are working at Ahmedpur or Azamgarh, or whether you are practicing Mumbai or you are New York, is same. The moment you put it on your paper, patient came for the first time at 32 week. I have carried out the test today to know the status of the baby inside. There is no controversy about it. So make sure that whatever gestation she comes to you, make it a note. You have come for the first time and carry out your proceedings accordingly.
Yeah, great.
Okay. So with that, because I've been receiving phone calls now, so we come to the end of this panel, and some take-home messages for the audience, for our viewers, would be that modern prenatal testing plays an integral role in pregnancy, and it is essential for obstetricians to be aware of the availability and usefulness of prenatal testing. First trimester, which is 11 to 13 plus 6 weeks, is the best time to screen for aneuploidy, and FTS comprises of maternal age, NT, free beta HCG, PAPE, and secondary markers like nasal bone, tricuspid flow, ductus venosus flow, if the expertise is available. And EFTS, which is enhanced first trimester screen, not only increases the detection rate of aneuploidy, but also predicts conditions with adverse pregnancy outcome like preeclampsia, fetal growth restriction, preterm labor, etc. Quadruple marker still has a role to play for mothers who have booked late, that is from 15 to 21 plus 6 weeks. And greater obstetric vigilance is needed in COVID times, as a lot of mothers have missed prenatal screening and detection, and invasive testing in the late third trimester is controversial, considering the Indian scenario. That would be my last word. So I really thank each one of our esteemed panelists, and I'm sure that our viewers would have benefited, by, and I really don't know how to thank Dr. Jaideep Tang for really selecting the panelists. He has just brought together all the stalwarts in fetal medicine and imaging science together on one platform. I think we wouldn't have had this advantage even in a real, in a real meeting, unless until it was a dedicated fetal medicine conference. So thank you so much for all your inputs. I really enjoyed, interacting with you, and I'm sure our viewers would also have enjoyed a lot and must have taken some good take-home messages. Thank you so much.
Thank you, Pragya. It was very good selection of cases, very nice cases that you put up. And of course, Jaideep has to just make one call and everybody will come. So
Thank you, Dr. Jaideep,
Thank
Dr.
you.
Pragna,
Yeah.
Dr.
Thank you,
Luna
Dr.
ma'am,
Pragya.
Dr. Mandakini ma'am,
Thank you, Dr. Pragya, and thank you,
Dr.
Dr.
Minu,
Thank
and Dr. Prashant.
Thank you. Thank you very much. I
Thank you,
hope
everyone.
everyone is happy about it, and thank you very much.
Yes, I think I can factually say that people are happy about it, because the comments that we've been receiving in the comment section have been extremely appreciative. And if the comments were not enough, I'm happy to inform you that the attendance at the end of the webinar is much higher than the attendance at the beginning of the webinar, which is always a sign that the audience was extremely engaged. There are 2,676 people logged in even now at the end of the webinar. So I think that's a testament to how engaging both the panel discussions were. So thank you very much, Pragya, again, and all the panelists. Quite a wonderful panel discussion. I learned a lot. I hope the audience also enjoyed it. And Rohan, can I request you to please take it from here?
Thank you so much, sir. I think today's session has been a wonderful session with such interesting discussions and amazing take-home messages. And I think Jaideep sir has already thanked all the moderators and the faculty for taking out their precious time and coming for our obstetrics masterclass series. So thank you, everyone. And we look forward to seeing you again next Wednesday, that is the 16th of December 2020 at 7 p.m. again. Our topics are going to be breastfeeding notes from the postnatal ward, calcium, and PIH. And we're going to have a panel discussion on obstetric anesthesia and analgesia. So looking forward to seeing you all. Of course, this program would not have been possible without our educational partners, Torrent Pharma, Maruti. They have a video to show, and Mr. Krishna Reddy also wants to say a few words at the end of the session.
Thank you, Rohan, for having taken the pains, in helping Dr. Jaideep Tang for organizing this program. And you have been quite, on your toes really for this program to be successful. So thank you once again. Yeah.
Pragya ma'am, can you stop
Sure.
sharing?
Yeah. I'm just going to do that, stop.
Thank you so much, ma'am.
I think you've done it, no?
Yes, ma'am.
Yeah.
Maruti, could you please share your screen?
Yes, sir. Yeah.
The triangle of B complex is essential for pregnant women in their dietary process, as while conceiving, women find it difficult to produce adequate levels of vitamins. With external supplements, they get their required dosage, which is ready for absorption and utility by the body. Vitamin D also is most crucial in pregnancy and lactation. For prevention from adverse outcomes, future risk to health of child, and maternal and fetal health during pregnancy. European Society for Pediatric Endocrinology confirms vitamin D3 2000 IU per day ensures adequate vitamin D status in pregnancy and early infancy. Vitamin D3 supplementation helps achieve the sufficiency and can be taken for a long duration. Calcium also plays an important role in pregnancy as its twofold requirement increases. Adequate maternal health is needed for fetal bone health, and as per the BMC Public Health article, calcium supplementation during pregnancy reduces gestational hypertension by 45% and preeclampsia by 59%. Effective management of pregnancy demands supplementation of prenatal vitamins. This supplementation provides protection against various defects that can occur during pregnancy. Shellcal XT provides protection against neural tube defects. It reduces the risk of preterm birth and congenital heart diseases. Shellcal XT contains 1250 mg of calcium carbonate, which is required to maintain maternal skeletal calcium. 2000 IU of vitamin D ensures adequate status in pregnancy and early infancy. Shellcal XT has 1000 micrograms of L-methylfolate. Journal of Clinical Pharmacology and New Drugs confirms that L-methylfolate helps in decreasing the risk of NTD by 72%. The methylcobalamin at 1500 micrograms improves pregnancy outcome and maintains normal folate metabolism. The additional pyridoxal 5-phosphate at 20 mg reduces nausea and vomiting in pregnant women. From preconception, pregnancy to lactation, Shellcal XT is a world-class product for vitamin supplementation. Shellcal XT has special coating technology and vitamin D3 in stabilized form. Shellcal XT helps to reduce the pill burden. Dosage of Shellcal XT is 1 tablet once a day. Each ingredient in Shellcal XT is coated separately, so there is no drug-to-drug interaction. Shellcal XT scored tablet gives dosage convenience. A healthy start leads to healthy mothers, and healthy mothers make a healthy generation. After all, every pregnancy is precious.
Yeah, good evening, respective doctors. We are in the concluding section of this live video conference. It was exciting and enlightening and knowledge sharing. And I'm sure you all must have learned some new things, also got the chance to interact with experts in field of gynecology through question and answer session. And on behalf of the entire team of Torrent, I would like to thank our chief guest, Dr. Sirish Shet, sir, series convener, Dr. Jaideep Tang, sir, and series co-convener, Dr. Pariksit Tang, sir. Moderator P.K. Shekharan, sir, Dr. Pragna Mishra, and Dr. Rohan Palsetkar. And the list of panelists are Bhaglakshmi Nayak, Huma Pandey, Dr. Hanshu Raina, Dr. Sarita Agarwal, Dr. Haresh Doshi, Dr. Maninder Ahuja, Dr. Mandakini Pradhan, Dr. Meenu Agarwal, Dr. Prashant Acharya, Dr. Sita Pai, Dr. Rajendra Singh Pardesi, and Dr. Luna Pan, who have given us time from their busy schedule. This program would have been incomplete without your experience and knowledge. My special thanks to all the audience for making this live video conference successful. Thank you all.